meeting will be recorded and broadcast throughout Parliament buildings and online. Do we have any apologies? No, okay. We're going to go straight to the members' briefing, or the minister's briefing, sorry, and then we'll do these other issues afterwards. So, if we can invite the Minister and the Permanent Secretary in. Can I just refer members to tab 5, includes a paper on the June monitoring round, a response from the departments at page 17 of table papers to inform the committee, information to the committee required following last week's briefing from the BMA GP committee. And can I welcome Minister of Health Mike Nesbitt, Mike Farrar, Interim Permanent Secretary, and David Keenan, Acting Finance Director. So you're all very welcome before us, and we believe we have 90 minutes now.
Yes.
Thank you. We appreciate that. So, Minister, I'm going to hand over to yourself just for a brief introduction, and then we're going to open it up to members.
Chair, I think because the agenda has changed and broadened, we were able to adjust the diaries, so 90 minutes, but it is a hard deadline. Yep. So before I turn to the wider budget position, I'm conscious that the GP contract situation is of great interest to this committee. And the first thing I want to say is it is a matter of regret that the department wasn't able to reach agreement with the BMA in relation to the 25-26 GMS contract. As I said in my statement last week, my door remains open. I want to discuss how we can secure the future of general practice, and I do believe we can move forward and work together to develop a shared vision for primary care, and there's a lot that we do actually agree upon. I'm also heartened that the BMA General Practice Committee had a very constructive discussion with my Permanent Secretary, not on the contract issue, but on how we build up primary care as a central part of resetting the entire health service. And I want to make 3 points on the contract and the subsequent controversy around my decision to implement the package for this year. The first is this: I simply do not have an extra £80 million to meet that BMA demand. That, I'm afraid, is an unavoidable fact. Secondly, the additional £9.5 million within the new contract, it's only part of the picture of GP funding this year. We've also secured significant funds to expand the MDT model and primary care elective care. And last week, I also made it clear it's my intention to deliver the DDRB pay award. GPs, therefore, will receive a further £11 million. So it's simply not the case to say we're disinvesting in primary care. The opposite is the reality, but I do wish we could do more and more quickly. Thirdly, I fully intend to invest more in GP services and primary care in the future, and this will involve developing proposals for a new neighbourhood health model that delivers more care in primary and community settings to enable people to stay healthier for longer, and it will reduce the demand for expensive hospital-led care. This shifting of care would necessarily be accompanied by a shift of resources from secondary to primary care. GPs and others stand to be the beneficiaries of this shift, and I want to work with GP representatives to ensure a stable general practice is at the heart of that neighbourhood model. Then there's the wider issue of improving patient access, and I want to be clear, I recognise the complexities and the challenges involved. It's undoubtedly a source of huge frustration for patients, and we all know that from our daily contacts with constituents. I get letters regularly from MLAs urging me to do more on primary care access. And whilst additional investment is part of that long-term answer, there are further improvements we know we can put in place now to help make a start. The GP contract for 25-26 includes measures to remove some of the access friction points that can make the experience worse for patients and for practices alike. And in many cases, these are things that practices here are already doing, and we simply are seeking to spread that good practice across the region. The reality is some practices are struggling more than others on the access front. I want to address that constructively, collaboratively, but as MLAs we must recognise this issue was always likely to be a source of debate. I know GPs want the best for their patients, and they're extremely frustrated at the current mismatch between demand and capacity. And I meet enough and engage with enough to see how hard they work, and so I salute their work, the work they do and the commitment they have to public service. Let me now turn, Chair, to the overall financial position. With the final budget now confirmed, we'll be faced with an incredibly challenging financial position where we will again have to manage a significant funding gap and will not be able to do all we need to do or all I want us to do. I recognise the importance of attempting to align funding to the programme for government priorities, and that this has driven the ring-fencing of a significant proportion of the funding available to me. However, the additional pressures that the final budget adds in terms of the ring-fencing of some 165 million of the general allocation for waiting lists and the difference in the allocation for the rise in national insurance contributions compared to the original planning assumptions has increased that funding gap further. When we take account of the latest pay review body recommendations, which I trust we as MLAs can all support, this pushes the overall funding gap north of £600 million. So I'd like to be in a position where I could put substantially more investment into primary care, into social care and public health to best meet the needs of our population, but unfortunately this will not be possible with the funding allocated. This final budget settlement leaves me in a position where I'm genuinely struggling to see a way through to financial balance. I know it's easy for some to stand on the sidelines and say with a budget of over £8 billion, significant further savings must exist, but I invite any MLA to come and sit with the local Director of Finance in their trust to identify areas where savings can realistically be delivered. Given the quantum of the £600 million gap, I cannot see how it can be bridged this year through efficiency and service reconfiguration alone, although of course I will ensure as much progress is made as possible. Realistically, it's also extremely unlikely we'll receive significant in-year allocations in the coming year to resolve the shortfall. And while I will submit bids for additional funding in June monitoring, I recognise there will likely be limited funding available for the Executive to allocate. I recognise my department also has to do its bit to put the HSC on a more sustainable financial footing, and in that regard, the Permanent Secretary and I hosted a financial summit with trust chairs and senior executives at the end of April. This was designed to look at actions which could be taken to improve the in-year position as well as our medium-term financial sustainability. Now, this generated several actions, and a new systems financial management group has been established to take these actions forward. Mike may have further comments on that. I was also asked to briefly touch upon the legislative programme for this mandate. I'm pleased to confirm before the summer, pending executive agreement, I hope to introduce an adult protection bill. I also hope to introduce up to 5 other bills during the next 2 years. The bills are prioritised are the Control of Data Processing Act, Safe and Effective Staffing Bill, Minimum Unit Pricing of Alcohol, Pharmacy Technicians Bill, and a Duty of Candour. And Chair, with your permission, I'll now pass over to Mike, who provides some more information on this new Systems Financial Management Group.
Thank you, Minister. Can I just welcome the opportunity to speak to you at this early stage in my tenure? I really welcome the chance to give you some initial observations as to, I think, what we need to do. The first, and it's a large point, and it won't be the first time that this committee's heard it, is that when you look back to Raphael Bengo's report in 2016, he talked about the problems associated with this ever-voracious appetite for health and care to draw on the Northern Ireland budget, and it was stood at 46% of the total allocation in 2016. As we speak today, it's over 50%, touching 51%. If we went on at that rate and we didn't do anything to address that, Northern Ireland will be looking at something in the region of 75 to 80% by 2050. And of course, that's at the expense of other budgets like education, communities, environment, etc. So it simply isn't tenable to carry on in that sense, and we've got to be mindful of that. In that context, I am saying that my role is to address that, and that means that we have to get better value for the money that we have, and we have to effectively reset the way that our system works. And to make it really simple, largely we've tried to tackle some of the problems of increasing demand on healthcare by addressing it through looking at increasing supply. And that really isn't sustainable, and those countries across the world that are facing similar challenges have a very different approach and are starting to look, as we will be, at the demand side of things. So in that context, we are keen to produce 2 documents, I think, that'll be helpful to the committee. They both are designed completely to underpin the vision that Minister set out with his stabilisation, reform and delivery. It's not a new report. This is basically just saying how we're going to achieve it. And there are two elements to that in time frame. One is the most immediate thing, which is about how do we effectively deal with our in-year financial problems this year with the £600 million. Really important there. As we speak at the moment, the System Financial Management Group is now in place. It's overseeing 13 work streams. It's on an emergency footing, so we talk about our sit reps in the way that some of you will be aware is about how do you report on emergency situations. Those 13 work streams are looking at every aspect of our expenditure, including central budgets, as well as the local ones by the Trust where the vast majority of money is spent. And they are designed really to get as close as we possibly can to balancing that 600 figure. But with the best will in the world at this time of the year, I inherited the plan, if you like. Getting ourselves 10 months of activity, we are going to struggle. And therefore, as you're aware, because the Minister made a statement to the Assembly that in terms of the immediate pay award that we face, which is a £200 million bill, I've had to use my accounting officer duty to point out that that's not affordable within the current budget arrangements, and there'll be some process that follows that. The most important aspect of this is that we are absolutely looking at efficiency across our system, but it's also accompanied by the second bit, which is the resetting of the health system. And in that we will be looking at increasing our focus on prevention, using citizens as assets. There is some very good work that we can, I think, plagiarise, which is getting citizens responsible for their own health, working with our voluntary sector, supporting them to manage their own health and care problems where they can, but also to access care through things like pharmacists, etc., as well as their general practitioners. The second bit is really around the neighbourhood model of health. Again, a lot of systems have this. We have pieces of our jigsaw, but we've not put them together in a coordinated way. And in fact, one of the conversations I'm having this week is with the Department of Communities, looking at how do we connect what we're doing on health with the care planning process that we have to make that more coherent. But this is really about trying to get people's care in the community in a really effective way that avoids them either losing their independent living or going into hospitals. And so some of our services currently provided in hospital settings, our intention is to move those into an earlier access position where we can diagnose and treat people sooner and more effectively. But we'll also be looking at how do we use our resources to support other government initiatives, thinking about the whole system. Members may be aware of places like Canterbury, New Zealand, where they took the whole of the public expenditure and really were able to get better value out of that. And I'm working on things like economic inactivity, young people's mental health, trying to increase the opportunity for inward investment through life sciences, innovation, etc. And then we get on to some of the more significant areas like using our data. Encompass provides, I think, one of the world's leading health data platforms. I only know of Singapore that has something similar where all their providers of services are on the same platform and they don't have social care, we do. So I think we have a world-leading opportunity to use our data and digital engagement to really transform care. And then we're looking at the cost base again, which is our kind of approach to our costs. Unwarranted clinical variability is a big issue for us. In particular, looking at primary care, some practices manage a whole bunch of chronic diseases, whereas other practices it flows through into our hospitals. So looking at that unwarranted variability, that needs clinical engagement and leadership, and we've got to address the culture of that as well. And then finally, being much, much faster at innovating. The technology plays that everybody talks about, things like AI, definitely can be helpful, but if we don't have a culture of adoption at pace and scale, then that is going to sit there and potentially even cost us more than it should. So those are the 7 areas that we'll be looking at in the reset. Alongside that, we have to change the operating model. And I know one of the things that the committee has been concerned about is the way the trusts work together. I can tell you that even within the first 7 weeks, we've got commitment that there'll be an approach called Committees in Common, which all the trusts have agreed to, that will work together to take shared binding decisions. So we see the whole system as a system with its workforce and its estate, and we were able to sort of capitalise on that. But obviously that's in the, I'm getting into a bit of detail, I don't want to at this stage. So just to say thank you for the opportunity to speak to you. I'm happy to go into more detail on the short-term financial management and also the reset. But my stark point is that Northern Ireland cannot keep on going in terms of demanding more of the public expenditure for health. We have to now reset our system to be more effective and efficient at what we do, and it very much supports the Minister's vision for what the health and care system should deliver. So thank you.
Okay, so thank you very much, both of you, and I should have welcomed Mike. This obviously is I give you a special welcome to your first committee meeting. So, Minister, I've had a lot of engagement with GPs in the aftermath of last week's statement, as you would expect. I mean, they were hurt and upset about two things. One, the nature of the funding being given to them for core funding, and secondly, the tone of your statement that upset them probably even more. It's not good from anybody interested in the health of our population to have the Minister at loggerheads, as it were, with general practice and GPs who are instrumental in providing healthcare for our citizens. So, I mean, I think I'm welcoming a shift in at least your tone today, which I think is good. I accept and welcome the fact that the BMA GP committee had a positive meeting with the Permanent Secretary. But that also then leaves the issue of the funding, which, I mean, I assume they are still extremely concerned about. So we had asked a number of questions last week, and we got a written response back from yourself in advance of this meeting, which addressed some of those issues. We specifically asked about the cost of locums and trust-run services compared to GP independent practices. And the figures were a bit of a shock to me, even though I was expecting them to be more. They are substantially more. So, I mean, trust-run practices cost substantially more. That's according to your own figures. Are you worried that, in essence, by not giving additional funding for core services for GP practices, therefore putting GPs under pressure? They say they're under pressure financially and in terms of what they can do to provide extra access. So that actually pushes more GP practices maybe to hand back, so we might end up having more trust-run practices, which is actually totally inefficient and undoing the policy that you are stating, which is shifting left, because we will actually have two things. We will have less patient access, and we will have a substantial additional cost to the public purse. So your policy, in effect, is actually undoing what your stated end game for your policy is. Are you concerned about that?
Well, I am concerned that I can't do all that I want to do as Minister, and particularly do all I want to do in terms of that shift left into primary and community care. But I did put another 9.5 million into the system.
1 million.
Yeah.
It's only 1 million, Minister.
Yeah.
It's 1 million into the core envelope to be used as they see fit, but it's also 5 million for indemnity, which had become a highly, highly toxic issue before I came into post. And 3.5 million, and actually that was a minimum of 3.5 million to cover the additional hike in the national insurance contribution from employers. And they made the point to me that they didn't think that would cover it, and I made the point back, well, you will be able to prove what it has cost through your receipts, and if the receipts are more than 3.5 million, I will guarantee that we will cover that additional cost. So we have done what we can, but I have to go back to the point that I did want to help more. And so when I first heard about the additional 80 million, or 1%, I did on a number of occasions ask for a one-pager, just set out what you will do with that 80 million pounds. And I didn't get it, and the reason I didn't get it was there were going to be no additional services.
But, I mean, we met with the BMA GP last week, and I mean, they're very clearly telling us, I mean, we're not disputing there's 9 million going in, but 1 million of that only is for core services, which is what we're having this conversation about. And what the BMA GP are saying, or GPs are saying, they need additional funding to provide more access. That, I mean, it's as simple as that. That's. I mean, my question to you was that we're, from your figures, paying like 4 million for trust-run GP practices. So that's an additional 4 million. If that money was actually pumped into supporting GP practices, we would have less GP or less trust-run practices, and we would have more access to patients.
I think it's quite a complicated picture in that certainly locums are expensive, and one of our focuses this financial year is to try and reduce the spend on locums. But then you have salaried GPs, and there does seem to be an established trend, particularly among younger GPs, to say we would rather be salaried than be practice owners, to be business managers. So there are three different areas at play here. Do you want to add to that now?
Yeah, I mean, I think there is an issue about, if you look at the number of practices that are handing back contracts, that's actually going down over the last 2 or 3 years. It's a big decision, obviously, for a general practitioner to hand back a contract. Where I think the trusts have taken that on, they have been able to recruit salaried GPs. So in essence, there's a question mark about the comparison of the costs of care. I don't fully accept the BMA's position that they are increasing cost compared to general practice. I think that would be testable. We can certainly explore that. And one of the problems that we have is when you look at GP earnings, if you like, in the context of what the practice receives, that's very flexible. They're independent businesses. They can choose to employ more GPs, or they can employ nurses. As long as there's one practitioner, GMS registered practitioner, they can operate as a practice. So the extent to which they take money out of their contract, i.e. that they have a lucrative business that they can afford and gets good salaries, is very variable across practices. So some of the indications as to how those kind of claims are, I think, are very testable. The one thing that I would say, which I absolutely fully in support of the Minister, is that if we are to invest in general practice, I think it has to be not for more of the same. And I say that because even when we were substantially funding general practice in previous years, we have seen difficulties and the trend of people passing. I've got figures in front of me that, talk about how many practices have been in crisis over the years. This has been happening before we got into this year. And really the solution for general practice has got to be to invest in a new model of care where we are supporting them with a bigger workforce, putting them at the heart of communities as a navigator with pharmacists alongside them, with the multidisciplinary team professionals. To me, that is what we should be investing in. And so, sadly, we have a very difficult financial position. But if we're looking to the future and investment going forward, I think the question for the BMA is, do you support that new model of care? Because that's something that we would be, I think, investing in as the money allows, because it really reduces the demand.
I'm sorry for cutting it, because everybody's limited to time. So,
yeah.
the Minister said about more of the same. You've now said more of the same. Essentially, what I think the GPs want. GPs provide primary care to patients. Yeah. So, more funding allows them to provide more of the same, so they have said more funding will allow them to do more of what they do, and including the additional stuff that you want, but they need more funding to do that. So I'm not asking for a rebuttal that other members, I'm sure, will come in on that, but I think I need to make that point. Secondly, Minister, our next point, I suppose, is I should declare I actually was a patient of the cardiac unit in the Royal Victoria Hospital, so I was treated very well, I should say that at the outset. And I also need to say I haven't seen the report, but it's been widely reported. Shocking, the contents, if they're accurate in terms of what's reported. As members of the Health Committee, as I say, we haven't seen it, or at least I haven't seen it. So can I ask when we and the public can see the contents of this report and the recommendations contained within it?
Well, we were discussing that today. I did, I think, previously make a commitment, to Mrs. Dodds, that I would lay the report in the library. I'm now being informed that I've been slightly premature in that we need to take legal advice about the report because it may identify individuals, and we need to be very careful about not provoking legal action. So that is the problem. But Chair, as a more general point, it was a devastating report. a very bad culture was allowed to develop, and that demonstrated itself in behaviours, and in the fact that there was a terrible breakdown in relationships, with one surgeon walking into the building and others walking out and saying they were working for home. So I have written to the chair of the trust, and I would say the language that was used in that letter was robust, to say the least. I am hoping to meet him tomorrow, because I want to be able to look him in the eye and assure myself that he understands fully how seriously I'm taking this issue, and that the expectations that I have defined in that letter are equally understood. And we will meet again next month, because he is assuring me that the recommendations are being implemented, that an implementation action plan and oversight group is being formed, that the independent group who came out with the report will still be engaged to make sure that implementation is happening. So I'm treating it extremely seriously. But I should also make the point, because there will be people who are imminently going to the cardiac unit for procedures, that we believe, and that report suggested at the moment, it is clinically safe. It would be allowing the behaviours to continue that takes us into an area of risk. And I declare I've had 2 procedures from that unit, and potentially life-saving, and very grateful.
So, Minister, you talked about the seriousness of it. So, rouse, abuse, bullying of junior staff by more senior staff, surgeons not coming to work, throwing of medical instruments during operations. One consultant allegedly being told, if a patient dies, I will tell the family it was your fault. Behaviour putting patients at risk of harm, as stated, and reportedly when staff made complaints to the Belfast Trust, the result was extremely slow to investigate. So this is what has been reported as being in the report. I mean, it is shocking, and it's absolutely extremely concerning. It's difficult to assure the public, given that, and I mean, it's even difficult to assure the public. I mean, because this was investigated in December 24, or the investigation was commenced in December 24. So I assume you were aware of this on December 24. It's maybe a wee bit incredulous that we still haven't had sight of the recommendations, that we don't know what you suggested to the Trust, what the Trust was suggesting, and whilst this investigation was going on, because these are behaviours that clearly, when you're told about them, you don't need 6 months to become alarmed to actually try and address some of that. So, it would be, I mean, I actually thought you said in a question to one of us the other day that you were meeting the chair of the Trust that day. I'm a bit disappointed to hear you haven't met the chair of the Trust. I want you to give us assurance that you are taking it seriously, that the Belfast Trust is taking it seriously, that the recommendations, we need to see, the public need to see these recommendations to be assured of their confidence in this life-saving unit of one of our hospitals that is funded publicly. So, I mean, I think you need to maybe go a wee bit further in terms of your assurance that people are safe than you have so.
Well, could I add this, Chair? The bad behaviour was among staff. It wasn't by staff towards patients, and I think that's an important point to make. It doesn't make it acceptable, but it is important to say that no bad behaviour was reported between surgeons or other members of that 250-strong team and the patients they were dealing with. But I accept, if I'm due to go for a procedure tomorrow, next week, next month, I'm now looking at it differently than I would have done before this report was in the public domain, or reports of the report came into the public domain. But I can only assure you that I have not signed off on a letter as strongly worded in the year that I've been in post as the one I sent to the chair. And I say I'll be meeting him tomorrow, and then I'll be meeting him for a follow-up, giving him 2-3 weeks to make sure the actions are in place. And the independent people who wrote the report will be the same people who will be coming to me and saying whether the action plan and the recommendations are being implemented as they should be.
I accept that what you said about the legal advice with regard to the report itself, but I would have thought the action plan and the recommendations could certainly be made public. I think that would go some way to
Certainly take that away.
Assuring the public.
I have no desire to prevent you from seeing what is in the report, but I have to take the legal advice that I'm given, which is to seek legal advice.
Finally, from me, Minister, because you raised the fact that it was not staff against patients, it was staff against staff. I mean, I have questioned a couple of times on the violence from the public in EDs and other hospital and healthcare settings, and the threats of violence against our hard-working healthcare staff. You know, the levels of that are extremely high and need addressed. So I was particularly concerned that in some of our healthcare settings that some of our staff are actually being bullied and threatened and harassed by their colleagues. So I think that is extremely upsetting and worrying. And I asked you the other day about engagement with the unions. You know, I heard in some of the media outlets today even further concerns that this maybe isn't isolated. I don't want to go into the allegations that were made, but I genuinely think that you need to be engaging with our unions. If there is a pervasive situation across all healthcare settings where junior staff feel bullied, harassed and intimidated, then that needs serious addressing.
Two more points if I may then, Chairman, very briefly. I'm also asking for an urgent meeting of the Royal College of Surgeons because I'd like to know if they're going to take a view on this, particularly with regard to any ethical codes that they may have. And the second thing is, I cannot look you in the eye and say this unit is an outlier. This was a cultural issue. It would not surprise me if cultural issues existed in other units within our arm's length bodies, including those 5 geographically defined trusts. And sometimes when something like this comes into the public domain, as you know, it effectively gives permission to other people in other units to become whistleblowers and to put their hand up. So we are on standby for that eventuality without any knowledge that it's coming, but the logic says it's highly possible.
Thank you. Dan?
Thank you, Chair, and thank you, Minister, and welcome to you, Mike. I'm sure it will be the first of many encounters that we have here in the Health Committee. So just following on from the last set of questions from the Chair, there's a couple of things that I would like clarification on. The report actually not only talks about bad behaviour between staff, but the failure of the Belfast Trust to actually manage that bad behaviour and take action in support of staff who felt bullied, etc. And I think that is a huge failure in terms of a very large organisation, and that's clearly stated in the report. So therefore, I have had contact from various people since Tuesday. And the one thing that is becoming clear to me is that this is not isolated to one unit in the Trust, and that this is exacerbated by weak management and a failure to actually deal with issues as they arise. So I would be grateful, because I'm interested to know when the department and either Minister Swan or yourself, Minister, actually became aware of this mismanagement within the Trust. I have been told that Peter May commissioned a report into these weak management structures in the Trust and the failure to deal with bullying and issues, and that report was written by Mr. Peter McBride, who has presented to us on the Being Open framework. I understand that report was presented to the Trust, but I am unsure if any actions have been taken, and certainly the fiasco in the first quarter of this year in the cardiac surgery unit would indicate that very little has been done. So again, I would ask, when did you know that this was a cultural issue in the Belfast Trust? Do you have, and have you had sight of the report which was commissioned by Peter May? Will this committee be able to see the report that was commissioned by Peter May? and what is going to be done, bar strong letters and, Minister, I'd have to say some plausible deniability from yourself on the matter?
Could you expand on the plausible deniability?
Well, I don't know. I want you to set out clearly when the ministerial team in the department knew about this issue and how long it has been going on and why action was not taken so that we arrived at that crisis point in the first quarter of this year that is described in this report.
Well, I would need to go away and come back to you because I don't want to commit myself to saying I knew on such and such a date. But in my role on an almost daily basis, one of the things that I get briefed about is a problem. There are a lot of problems. There's 70-odd thousand people delivering healthcare. Inevitably, there are problems. I have not seen this other report you refer to that you believe Peter May commissioned, so I'm not aware of it, so I haven't read it. And I think it's important to say, which is not to deflect from my responsibilities. My responsibility is to make sure that the trusts and the trust boards are doing their job. And there is a question mark over the Belfast Trust and whether they've been doing their job in this instance. But they are effectively the employers. And if there is to be action taken to remedy a situation like the one that has developed in that cardiac unit, it is primarily for the trust to take that action, and it's for me to make sure that I hold the trust to account and that they are taking appropriate action. Is there anything you want to add, Mike?
Well, this is the first I've heard about a report that Peter commissioned from Peter McBride. So we will obviously look into that, but I'm not being made aware of that.
That's fine. So just again for clarity, actually being able to read that report would be very, very helpful. I think we as a health committee, scrutinising the department and the trusts, want to know that people are doing their job, that staff are being looked after, that patients are safe. And I too have read, according to the metrics, the unit is safe. I'm not querying that at all, and I don't want to have anybody fearful going into any serious operation within that unit. So I'm not saying that in any sense at all. But I do think it is important that we are given the information in the interest of openness and transparency to be able to do that. And I think that is important. Can I ask, just a more general question then about the Belfast Trust. Over the last year, we have seen a fiasco around the maternity hospital, the children's hospital, an energy centre where we spent 10 million of public money, which the department, in your answers to me, Minister, quite openly says cannot be delivered. And now the acute mental health inpatient centre in the Belfast City Hospital site. I have called, and I continue to call, for your department to put some kind of special measures within the Belfast Trust so that we stop this litany of problems that actually are coming from that particular trust. When will you get a grip of the issue and put the trust into special measures? And I noticed your interview yesterday, Mike, where you did talk about that possibility. I welcome that, but I think we're beyond the time of action.
Can I just go back to this
Of course.
Peter McBride report?
Yep.
I'm going to go away from here, find out if it exists.
Yeah, no, that's fine.
With a view to sharing it with you, but so that I don't have to correct myself again. It may need again to be looked at by the lawyers, just in case there's identification of individuals.
Yeah,
but my hope would be that if it exists, that you get it in a very timely manner. In terms of interventions, there are 5 points on the scale of interventions, and the Belfast Trust is at 0.4. And 0.5 is what you are calling for. But that is not a punishment, that is assistance. And I'm reluctant at this stage, not least because we are approaching the final stages, I believe, of appointing the permanent replacement chief executive. So I think that person needs to be given an opportunity to put the house in order, if that's an appropriate phrase. And that's fairly imminent, Mike? It's well advanced.
We're shortlisting today, and interviews will be early July, and obviously that's a key appointment. There's one point of principle, I think, because I really understand where you are, and well, actually, there's 2 points of principle. One, if there's learning from this, which there is, it's about creating cultures that are healthy in a preventive sense and a positive sense, and actually this is something that we have to do with our workforce, and we will push hard as part of resetting the system, that actually these cultures that have existed in trusts, we can't tolerate that. This is not where we want to be. And, you know, whilst it's being in the mix, things like the duty of candour are actually helpful, but we should never have to legislate a duty of candour. If you think about professionals in a healthcare business, we should never have to, but we are where we are, but we will be promoting that. The second thing is that the level of intervention in the systems intervention framework really, in essence, places the responsibility out there with the boards to be managing this on an ongoing basis. And so when we come to a level 5 system, and you made the point, you think we might be at that level 5 already. But one thing it sort of does in a little bit, if we're not careful, is that it takes away the responsibility on this trust board to really get to grips with this issue. And my personal view is that they are committed to doing that. They've commissioned this review. They are now trying to action it. I think at the very least we should give them the opportunity, because they are closest to it. And as the Minister says, if there are any disciplinary issues, that's within the jurisdiction of the trust, not currently with ourselves in the department. But if we are absolutely clear that they are not fulfilling their promises to deliver on this, I don't think we would have any hesitation. You know, but placing the responsibility with the trust board is the right place for it to be. And if they fail to deliver their duties, then I don't think we will have any hesitation in saying we go to the next level. But Minister's absolutely right. It's not a punishment. It just means that we have to put more assistance in that. And again, we've offered them as a huge amount of assistance now, but it is currently still within their gift to resolve it and to do it quickly. And the Minister will hear the progress on the action plan tomorrow, and then we have continuing monitoring meetings to make sure that they're on top of that.
We have to move on to the next member. Dan, I'll come back to you if there's time left. Linda.
Thank you. I'm following on from that anyway, just in terms of your last comments around, I suppose for me it's more important around the accountability mechanisms between the trust and the department. So I would like for us to get an understanding, and I'm happy to get that in writing, exactly, because I think we probably have to get it in writing, exactly what are the accountability mechanisms between the trust and yourselves, particularly given what has gone on. The next point I want to make is I would seriously hope that in this appointment process that you are looking at anybody who was involved in any part of what happened around the cardiac surgical team, because I understand what you're saying in terms of that this was not abuse of patients, but it was abuse of staff. And they are human beings, they are people, and somebody to go into a higher management role that potentially had some part to play in a management role in that, for me, would be extremely concerning. So I'm putting that out there. It's a HR issue. I know we cannot get involved, but I do think it needs to be something that there's a conversation around, and that it's considered, particularly in your meeting with the chair. Because for me, for a senior clinician, and that's what it sounds like, to say if this patient dies, it's your fault, that is abuse of a patient, that is abuse of their family. That is horrific. I can't even imagine what any family would think if they knew that was their person. So I think that is abuse of patients and their families. Just then in relation to you said that out of this there's potential for other people to come forward, that they're potentially, and that the chair is right, the unions were very clear this morning on the radio whenever they said there is a culture, and this is happening in other hospitals, in other unions, in other trusts, and they have evidence of it. So speak to them. Don't wait for people to come forward. Don't wait for people who are just trying to do their job, trying to cope with getting through because some of them won't want to report it because they just want to look after their patients. They're prepared to put up with this to look after their patients. So don't wait for it. Go and look for it. That is the Trust and the Department's responsibility. Go and find out. And if there was ever an argument for legislation around duty of candour, honestly, I think this is it. I do. I mean, and I never was totally convinced about whether there was or there wasn't. But this, for me, is the absolute. We need to find if there's a pervasive culture, not wait for it to come looking for us. I think that. So I would like for the department to come back to us also in relation to that, in relation to what work the department or the trusts are doing to ensure that this is not an issue, and that work needs to be done with the unions and with the staff. And just my last is a question. Would there ever have been a review into this had those surgeons not left when that surgeon came back? Do we know the answer to that?
I don't know the answer to that.
And that be a question that's asked of the chair. And
Yes.
if they want to prove their candour, this is their opportunity. You know that.
So, in terms of the broad point you're making, and by the way, I did brief the executive this morning on the situation of the cardiac unit. So, one of my concerns is because they were the only unit providing cardiac surgery in Northern Ireland, there is a potential implication for the other acutes like the Ulster and the City and Craigavon. So, I want to know if the relationships with those cardiac units and those other acutes in the other trusts, what were those relationships like? Because clearly there's a suspicion that the unit at the Royal, who were the ones doing the surgery, were, as it were, the big beasts in cardiac care. So there's that issue. I'm more than happy to commit that I will meet as a matter of urgency with the unions to see what they have to say. Certainly we will ask the trusts for their opinion about to what extent the culture in that unit is representative of the culture in other units within the 5 geographically defined trusts. So I'm not going to sit back on this, but I do anticipate that some people will come forward, and that is to be welcomed, because that is a very valuable, rich source of information. If a whistleblower chooses to come and inform us that you need to look at X, Y, or Z unit.
And we also get detail from the trust, if you don't already have it, on what they have done in the interim. This was the question I had asked the other day, and I understand it probably is something that lies within the responsibility of the trust, but it's information that we need to have of what they have done in the interim whilst this report is being in recommendations, because if they knew this is as bad as it was, you don't wait for recommendations. You would be in there immediately. I mean, it follows on from much of what Diana said. So if we can get that information through your meeting with the chair, or if you haven't already been given that.
I will say it's my intention to meet him tomorrow, and I'm more than happy to send a debrief to the committee on foot of that meeting.
Can I ask one question that is not related to the just in terms of financial plans, the objectives for the domiciliary care and social care work streams are still to be decided. I'm just wondering, is there a reason for this delay? And when can we expect then that will be decided?
That's probably with me.
Sorry, I know you have a lot to do with today, but the financial plans.
No.
So the objectives are in relation to domiciliary care and the social care.
So when that grid was put together, they were the work streams that came out of the financial summit, and at that point there was a particular piece of work that's been going on around social care run by the Social Care Collaborative. And so before committing in that particular document at that time, we were very keen to make sure that we weren't saying something that we already had in hand. That has now been updated. We'll send you an updated version. There's a clear set of objectives of what the social care work stream will do in terms of domiciliary and social care, in terms of looking at economies, efficiencies, and I would also say trying to improve the service. So we'll send you an updated version of that. And apologies, you got a version.
And to improve the service is probably my focus, to be honest.
Yeah, you got a version of that grid at the time, but it's been updated since because we've already started meeting, and so we can send you that.
Thank you.
Oh,
Thank
the
you.
accountability, sorry. And you mentioned the accountability. I think we could share.
Yeah, absolutely.
We've got a document which gives the 5 levels and what that entails, so we're happy to forward it.
Okay, thank you.
Thank you. Danny?
Thank you, Chair. And hi, Mike. Good to see you. Thanks for coming to committee. I just wanted to take up on one thing that you'd said early on there. You said that handbacks had been going down, GP contracts had been going down. Now, certainly that's in conflict with what we were told by the Minister a couple of weeks ago when in the Chamber you were asked just about contract handbacks, Minister, maybe you remember. You said there had been 16 GP contract handbacks since 23-24, with 11 of them being last year, so in the year 24-25. So that appears to be ramping up. So 16 since 2023-24, with 11 of them being in the last year. So there seems to be an increase in the amount of GP handbacks. And as we also heard last week as well, 17 practices across Northern Ireland are currently in crisis management. So the issue that GP contract handbacks appear to be going down, I'm just wondering if you could confirm that for us.
Well, the 16 is a split of 5 this year and 11 the previous year. 20. So it was 11 in 23-24, and last year, 24-25, it was 5. So in 2022-23, it was 13. In 23-24, down to 11. And in 24-25, down again to 5.
I just have to check what was in the notes that I've got, but certainly that doesn't meet the figures. Maybe there just is some clarity about that. But certainly hearing that number of GP practices closing over a couple of years, it is incredibly shocking. And having 17 practices now in crisis management, how many more GP practices are going to close here? How many more are we going to lose?
I can't answer that question.
I mean, this is an observation rather than something very specific, but if you look in the English context, a lot of practices have changed hands and become part of bigger groups, effectively. Modality, Operos, the Hurley Group, AT Medics have taken on practices. And so although individual GP practices have sort of not handed back their contract, but they've been taken over. So the key thing is, are we able to support those populations? And it's a legal duty that we have. When that practitioner hands back a contract, we are obliged to make sure that population gets primary care coverage. And that's what we have been doing. And effectively, of the 32 contract handbacks, effectively 30 of them the SPPG was able to immediately secure, and where there are unusual ones, where there are one or two that haven't been done, that's largely resulting of that practice not being sort of viable in that context, and so it's been effectively amalgamated. But so the sustainability of, I wouldn't want people to believe that means that no one has primary care. We have a statutory duty to make sure that happens. In an English context, you might not see it as a handback because those GPs have actually sold out to a bigger practice group, and this is a trend across the world. And you know, this is something which in Northern Ireland we have a profile of practices with a lot of small ones which are good for continuity of care, but sometimes scale is important as well. So
certainly what we have seen is quite a lot of handbacks, and a lot of GP practices are at risk at the minute. They're in crisis management, and when the trusts do have to take over the contract, we've seen the figures, and the figures are staggering. And as I'm sure you're aware, a practice that cost 760,000 to run in 22-23 cost 1,419,000 then in 2023-24. So that's doubling. It cost twice as much. Another practice cost more than 3 times as much to run. So when the contracts get handed back, there's a huge cost, as the chair had referred to earlier.
I think those are the figures when I saw them, and I might be they might be exactly the case, and I'm not sure where those figures come from. It's something that we would. They're my figures, are they? Okay, I'm not sure how we've counted them in that case, but I they have to shoot yourself in the foot at the first appearance. No, I genuinely, it is quite hard in the context of saying, well, how is the trust sort of running those on the basis of that very specific figure, because trusts get a general allocation, and how they've attributed the cost to those practices and what they've done, I'm not sure of. So I will happily look at those figures. The most important point of this discussion, I think that's the point you're raising, which is important, is that general practice really features very strongly in our model going forward. It has to. the model of general practice and the financing of general practice really needs to align with the model of care that we need to deliver, which is an integrated neighbourhood model. So we're very seized of that fact, and if in the short term we are having some issues with that, we need to accelerate the pace at which GPs feel confident that their future and their practices sit at the heart of what we want to do. This country should have the best population health management arrangement in the world because we have 99% registration. So we know all our people. You know, this is a real opportunity for us. We are not going to lose general practice. It will sit at the heart of what we do. We just need to bear with us, so we're investing in that new model. That's what we need to work.
Very glad to hear that, and I hope the GPs that are listening to this will be reassured by that. We've heard lots of times from the Minister about his desire to shift left in the bingo direction, but that means investment in primary care. We've not seen that investment in GPs, we've not seen it in dentists, we have not seen it in community pharmacists, and we haven't seen it in community groups, the core grant funding, for example. So we're losing a lot of community groups that are able to do all these things. GPs are closing, dentists are closing, and community pharmacy are under big pressure. So it seems to me that isn't working, that shift left isn't happening at the minute. How do you explain that?
Well, I don't think it's actually accurate to say that there's no additional investment in these services, because the GPs did get 9.5 million, the dentists have got just over 7 plus another couple of million for the national insurance. The core grant scheme was moribund when I came into post, and the advice from officials was to let it go, and I brought it back, albeit only at 1.8 million, and we did reconfigure it because any charity that had been established in the last 20 years couldn't even apply. Now, I don't think I'm satisfied with the way it worked out, but it was designed by the voluntary and community sector, and we are working with them to see how we can do it in a way that is maybe seen to be a bit more equitable. Now, having said all that, is 9.5 what I want to put into enhancing GP services? Of course it's not. I'd love to give them the 80 million. I'd love to give dentists what they want. I think they've taken a really practical and balanced approach by saying we understand that the Minister's got all these financial pressures, but the consequence of that is the money that you're giving us isn't the money for the radical transformation of dental provision that we need. I agree with every single word of what they're saying. So what I've got is a quadruple challenge. The executive, and I agree with them, have said prioritise waiting lists, so they've ring-fenced 215 million this financial year to spend on the waiting lists. But because 165 of that is not fresh money, that means I've got to mitigate the fact that 165 won't go on other services who might have expected it. The third challenge is the transformation. We've got to press on with the reform. Otherwise, once we've spent the money on the waiting list will go back up when the money's run out. Where do I find the money for the transformation? And then the fourth challenge is balancing the books. Can all four be achieved? I'm actually not entirely confident they can. But I'm certainly up for that challenge. And the biggest kind of disappointment within all that, I think, is the speed of the reform is going to be dictated by the funding gap. Because I think everybody's ready to do the shift left. I certainly am. But it does need that pump prime. And I think once you start that, and you put the more emphasis on prevention and early intervention, you might actually relieve a bit of the pressure on the acutes where all the expensive stuff is happening. And if you do that, you start to free up more money. And the money starts to shift left.
Absolutely, and I hope we can start to see
quickly,
that.
Danny, 'cause I think
Just
it's
wanted to
on your
ask one other question, and I agree with Diane's questions just about the cardiac unit, which was very concerning. I did want to ask you just for an update on the maternity hospital as well. We've heard that there was going to be a decision as to the way forward for the maternity hospital. Can you give us an updated cost of what's happening and what the decision is? And can you tell us when it may be open?
All I can tell you is that I have been told as of today that a decision or a recommendation from the Trust is imminent. But I don't know what it is, and therefore... Imminent, yes. So I don't know what it is, and therefore I don't know what the cost is.
Thank you. Noah?
Thank you very much, and welcome, Mike, for your first appearance at committee. I have quite a number of different topics, so my questions will hopefully be quite quick to cover. Just to follow on with regards to the GPs and the fact that the trust runs are a higher cost. And we know one of the issues is because they cover indemnity too. And I think that is in contrast to non-trust run practices. Another issue there that we've had feedback on as an entire committee is the salaried GPs, and the fact that there is a difference between the salaried and those who are the business run GPs, say the practice managers, the ones whose names across the door, and the comments I think made regarding what goes into their pockets essentially, and GPs don't have that static income until they give everything out to everyone. So I do think it is a bit unfair of a comparison to make, because GPs' wages do go down if they need to put in more money to their salary GPs to actually cover their indemnity, like which they had to do last year. So it is a bit of an unfair system, and hopefully we can now move forward with a different kind of tone and engagement with the BMA on that in particular. My first question is in relation not just to the cardiac unit, but following on from what Diane asked with regards to the issues at the Belfast Trust. Muckamore run by the Belfast Trust, Dr. Watt Belfast Trust, but it's not just the Belfast Trust. We have had serious respite and adult safeguarding concerns at the South Eastern Trust. We've also had the cervical cancer screening at the Southern Trust, and each of these issues, and there are many, many more that we all work on, that whilst the initial fault might not be with management, the reason why it went on for so long and it was ignored was because of management errors, because of management not actually doing their job. Do we have a problem with the way in which our trusts are run, that yet there's failures again and again? There's more scandals each year. I mean, Minister, are you content that we don't have a problem within the way in which our trusts are run, that there are more of these issues surfacing each year? I mean, the cervical screening one that's not over, and we still know that there's issues now with it being transferred to Belfast. Yeah. But do you have faith and confidence that our trusts are actually run not only as efficiently, but they are managed as appropriately as they should be?
I'm assured, or I'm confident that the vast majority of people who deliver healthcare in this country are well intended and well motivated. But there are then, you mentioned Dr. Watt, there are people who deliver bad outcomes. I'm
speaking particularly not about, because I agree with you, I'm speaking about not the ones who are delivering the on-the-ground healthcare, but the management, and not individuals, but the management ethos within across all the trusts. These issues just rumble on and on until a scandal breaks. And at some point, we always find out either in committee or an inquiry or through a statement you make in the chamber that the trusts knew about it, management knew about it, and there was failure to tackle it.
Yeah, and I would have concerns at times about the information flow, which is about the speed at which information comes to me, because often other people get that information so anecdotally or from whistleblowers or whatever, and I don't like to be in that position. I also don't like to sit in a room full of 27 people whose loved ones were damaged by Dr. Watt and have to listen to the human cost of what happened. And that is not just about an individual clinician. That is about the whole system. So in that specific case, the belief of all 27 in that room that day that this was a systemic failure that was allowed to happen.
How can we get a grip in it now? How can we get a grip in not just that failure, but just some of the ones that I've outlined there across management of all trusts? What can the department actually do?
Well, all I can say to you is I meet on a regular basis with particularly with the trust chairs, and they can be in no doubt that I don't want to hear about another scandal, about another episode where things aren't done properly, where patients or service users come to harm. And I think as a broad point, and I'll bring Mike in on this because I think this is an observation that he shares with me. Sometimes I think we feel that issues that arise within a specific trust are an issue to be dealt with by the board of that trust, by the chairman and their fellow board members. And on probably too many occasions, those issues are sent straight through to the department. And that should not be happening.
I mean, I'll make a general point and then a very specific answer. Quality is the thing that happens when no one's looking, right? So it starts with people being really concerned about the care that they give and making sure that every individual intervention with a patient, whether it's a nurse at a bedside, a doctor diagnosing, a surgeon in a theatre, they do the best that they can. So that's where we start. I then expect, and I think this is where myself talking to the chief execs and chairs of the boards, is that there is a real degree of scrutiny where they are more ambitious for having the highest quality standards than anybody else, that resides with them, that they monitor it and they are on top of that. And where we have problems, then they confess it and they open and they say, we have an issue. You could argue, I'm not arguing, but you could argue the fact that we have a number of areas that have been investigated is a good sign that these are being raised. Perhaps, sadly, too many come through whistleblowers, and I'm not trying to say sort of defend that, but actually, you know, we have to give quality. I genuinely believe that the management that we have, you know, works really, really hard to prevent quality failure. We will, as I said to members' questions, Diane's questions, you know, be looking to get a culture of really strong care. I think many people call it this compassionate care. I don't think there's any pushback to that. There are no excuses for very poor care, and I don't think any of our leaders at the local level would try and defend or hide that. I don't think that's the case. I'm, you know, new to the system at one level, but I think what I've heard is a positive commitment from all those leaders to tackle poor quality. One of the things that we struggle with, which is interesting, is that, but Encompass will give us, is looking at the quality of care when you benchmark one bit of the system against the other, sort of understanding whether or not a 6-day length of stay or a readmission for a particular procedure, you know, was necessary. It could have been tackled. I've mentioned once the clinical variability. So the data will start to highlight where we have problems, and the data will start to give us preventive information about where we can intervene, where quality starts to deteriorate. So in terms of a system that can address this, I would say that you've got two components. One is being smart about understanding where quality is at risk, and also making sure that managers are able and feel confident to report it when it goes wrong, because healthcare does sometimes go wrong, as you know. And, you know, we have to assure the public of Northern Ireland that when these things happen and are brought to the public attention, that we take action to address them so they can feel confident. But it is the exception rather than the rule. You know, the vast majority of clinical professionals are incredibly good at what they do. They turn, you know, well, even going back to our conversation about the cardiac unit, and I think it would be wrong if the public got the impression on the back of some high-profile failures that that's what their expectation should be, that care is poor. I don't believe it is. I think people of Northern Ireland get good care. And just one last point is that I absolutely believe, and I said this when I took the job, that Northern Ireland can have one of the best health and care systems in the world, but there are some things we need to do to get there, and one of them would be addressing some of these quality failures and preventing them in the first place.
One very quick question and very quick answer.
Well, it brings me on to the issue of respite. Like I said, respite in the South Eastern Trust. In particular, there has been a lot of issues there, but it's across all trusts. I wonder if we have any more update with regards to the number of additional beds and nights, or nights, preferably actual families that have been helped with the 10 million investment that was allocated into respite services, because we are hearing from families it's not making a difference. We know that it wouldn't have been quick, but there was still an expectation that at least would be some alleviation of the problem. They knew it wouldn't be quick, but they expected some alleviation.
Well, I think, Chair, it'd be best to write, because there's a level of detail behind that, and that wasn't on the original agenda. But I think over the summer and coming into the autumn, that's where we're going to see more beds being made available for longer, as in 7 days a week in some cases rather than 5. The number of beds is going to be limited. It is going to be very limited. But it's issues such as Redwood needed a staircase,
I raised that to you at the last meeting.
And that is either been done or it's in progress. And then when Redwood opens, that releases. Is it Lakewood? I'll write with the detail.
Okay, appreciate that.
Can I just one very
Sorry, it
brief
was 13 million. I got the figure wrong.
Right.
We'll
get back to that. But as part of the reset of the system and indeed managing the money the best way possible, carer support is a key factor there. If you look at where carers have been supported for things like managing relatives with dementia or Alzheimer's, they with very, very basic training and support and allowances, they are able to effectively have a major impact on the cost to the state. So I think you look out for carer support featuring in the way in which we deal with the public and the dialogue about health and how we can help ourselves. But that will feature strongly.
Thank you. Colin?
Thank you very much, Chair, and thank you, Minister, and welcome, Mike, to the committee today. Look, I'm going to follow on from what others have said about the Belfast Trust. It feels like every other week, it certainly feels that way, that there's another scandal that we're discussing regarding them, and I'm not entirely convinced that what we've heard from you today shows that the department is going to get to grips with this. It feels like, from what I'm hearing from you, that it's going to be down to the new appointment of a chief executive, but even from chief executive level down, there's always been a trust board, and the trust board has not been managing itself properly if it has allowed these cultures to permeate within their structures. And I think maybe it's a bit fantastical to just think that a new chief executive is going to come in and sort all the woes out. And you've mentioned the systems intervention model, and that we are at level 4 of 5 of that. But I just wonder, if we've got to level 4, given all the problems that there has been, is this system intervention model fit for purpose? Because it feels like there's only one more level left, which is to take control from the trust board into the department. But it feels like there hasn't been an awful lot done yet and since, with all these problems. And we think about maternity hospital, children's hospital, neurology, hypermetremia, these workplace, it just seems to be constant that there's things going wrong, but we don't seem to be getting any resolution. So is that model fit for purpose? And is stage 5 completely taking it into control?
Stage 5, as Mike said, is an option that's still live. But just to reiterate, it's not, to my mind, simply about appointing a new chief executive. It is about the board taking more control. And that is an issue I'll be discussing with the chairman when we meet. It is about the board saying, this is on our watch and we have to fix this. And preferably, this is on our watch and we have to ensure nothing adverse goes wrong, although things do go wrong. But those big scandals, like this persistent bad culture within the cardiac unit. So it's not just about one person coming in as chief executive. It's also about recalibrating how the board deal with the day-to-day running of that trust and the other trusts as well, of course.
And is there somebody specifically monitoring the board to make sure that they're carrying out their responsibilities correctly? Because if somebody's not monitoring that board, I mean, it's maybe long gone past the time that that board needs to step down and let a new board get in place to be able to take control of these issues.
Well, our only areas would be with regard to the appointment of the chairman, not to the ordinary members of the board.
Minister, that feels like you've no control of boards. Who are these people that run our hospital services so badly, and we don't have any control of them? That's not acceptable. We need to have proper control, and if people aren't doing their work right, they need to be shifted on. If you can't do that, that's very worrying.
I mean, I think you're making a very strong point. I think the issue is that in the event of us taking a view that we're at level 5, one of the things that would allow us to do is maybe to change the nature of that board by looking at the chair. The chair, in circumstances that I've been party to in the past, usually looks and says, well, I need to look at the executive, who are responsible, not just the board. And as has happened in many instances in England during my career, chief executives are removed. The fact is we have a new chief executive about to arrive. So in that circumstance, by volition, if you like, the trust is at a point where it's looking at its executive leadership. And I think that in the conversations that the Minister will have with the Chair, that these questions of are we fit for purpose, what actions are you taking about the strength of the board, the strength of the executive will feature strongly in that.
A colleague of mine said, Mike, in the chamber, and I think it's relevant here, it's like a culture of past buckery. It's just you keep passing the buck on. It's not the department, it's the board. It's not the board, it's the chair. It's not the chair, it's the chief executive. And eventually there's somebody further down the line. You don't change cultures by going away down the line and start dismissing people at that level. But I hope that you've got it contained. I know we're under pressure for time, and I want to just ask another question, Minister. It's about the GP practices. There has been some references to the funding model there. But can I ask you this, Minister, in terms of the tone, the issue about the one pager, I heard that as an insult. I heard it as an insult to the profession of GPs here. It felt like define your entire workload down into a few sentences, maybe a couple of pictures to make it easier. And it felt to them like their profession was actually being attacked from that. And I think that's the tone that many of us referenced that we felt was just disappointing. Do you feel that language like that is regrettable? And would you offer them an apology about that tone so that we can reset the relationships between people and start to work together to strengthen our GP practices for our communities for the future?
Well, I said in opening my remarks that when I came into post, I wasn't looking for a fight with anybody. When I first heard about the ask for the 1% or the £80 million, I did ask for what? And that's where I said, give me a one-pager. And that wasn't to define the entire body of their work. That was to give me some indication of what they intended to do with the 80 million, and it was with the intention of being able to say, hopefully, let's say there were 10 things on that list, that I might be able to say, well, I can certainly support you in 5, 6 or 7 of those, and I'm going to go away and fight to get to the money. But just to ask for £80 million was not a practical ask, and I made that clear in my statement. Of course, I mean, if people don't like the tone, that's a matter of regret to me, because all I was trying to do was state the facts, that on a number of occasions I asked for the one-pager, and that was trying to be helpful.
Well, Minister, if that was you not looking for a fight, I'd be careful on a night out with you just in case we get in trouble. But I think the regret was used there. I hope that is heard by the sector. I hope that we can get relationships reset and that we can get moved forward, because the primary care sector is just so important in the delivery of healthcare going forward. You've mentioned that. We all want to support you, but it's really difficult if relationships are bad. But thank you for what you've given and answers there, and thank you, Chair.
Okay, thank you, Colin. Ursula.
Thank you. Hello, Mike, and nice to meet you also today, Mike. So, yeah, just on this GP stuff, because Minister, I'm sure that you listened in, and your officials will have listened in last week and heard Francis speaking around this issue. Alan had asked questions around the one-pager and producing it. So they seem to be of the view that basically their asks for funding has been made clear throughout. So the point is about how you move it on. You say your door remains opened, which is great, and it's maybe then how you just get to the next step, and hopefully you can work this out and resolve, this, what is a dispute, because we're hearing one thing and then we're hearing another, but hopefully that can be worked out, because as Colin says, the GP sector is crucial to all the work that you are trying to do in terms of shifting left. So, and just on that, I know that you and Mike, both of you spoke about this reset of the system. It's great to hear around the 13 work streams that you have set up. The Systems Financial Management Board, I think that you had referenced, Mike. It would be great if the Health Committee could maybe see in terms of what actions that board is hoping to achieve, what outcomes the board's hoping to achieve, if there's any sort of timeline around that work. I know there's a lot in it, but if we could maybe get a breakdown of some of that as the Scrutiny Committee, so we can get a wee look at it and hopefully see things progress there. And then, yeah, so I suppose my question around, because you're saying, like, basically bear with us, do we try and move to this model? Everyone's on board. It's how we get there without the finances sitting here right now in our hands. But my question would be around, and I know that you need the money really to make this big shift, but see in terms of any official or structured engagement on this issue, right, on people being cared for in the community,
has there been any structured conversations with GPs, with community pharmacy, and with the community and voluntary sector in terms of how we're actually rolling this plan out? Because Danny had made the point, every single one of them are under pressure around their funding. We're seeing all the issues with the GPs at the minute, the community pharmacy minister, you know, that's been an ongoing issue as well, and then the issue with the community and voluntary sector. So I'm just wondering, how are you planning on getting all of these crucial people and groups on board to help with this shift?
Well, the great news is we've already started. So I think it was probably about week 4, we pulled together a summit of all the primary care interests, which includes pharmacists, the voluntary sector, care homes and care providers, GPs, GP federations. We had trusts there because actually a lot of the opportunity of working in communities to bring hospital services out into the community. In Alzira in Spain, their cardiology department was a community-based department, sat alongside general practice, only in reach to beds where they needed it, and we can do that. We can do that with probably paediatric care, we can do that with geriatric care, and we can really, sorry, they're horrible terms, aren't they, older people's care and children's care. We can do that, and there's a great appetite to design that model. We have some jigsaw pieces, MDTs being one of them, the multidisciplinary trust, the area integrated partnership boards are another that we've got. We have GP federations, we have the pharmacists who are really working hard. There is a huge amount, I think, that's going into general practice at the moment that could and would be dealt with by pharmacists, which will then release the general practice time to focus on the more of the complex chronic disease. And again, if they get access to specialist opinion sooner. Francis O'Hagan actually was talking to me at the second meeting that the Minister referred to about a scheme that runs in her area where they get support from a paediatrician, and that is allowing them to manage a lot of those children away from hospital, which is a great outcome. So we've got a lot of appetite and buy-in for that. My plan is that we would be looking to start to put that in place for next year at scale rather than just a pilot. And I'm calling it the neighbourhood model, but hopefully, you know, that's not just an all-catch term. It's really about dealing with you looking after yourself, needing immediate support, getting it, and where you do have a condition, getting the right decision at the right place in the community setting with GPs as your care navigator in that space. And it's not rocket science, all, but I think it's a really good model that we should get in place.
Okay, and I'm sure obviously the Health Committee, whenever we're engaging with those different groups and sectors, we will discuss that with them, and hopefully you do have them all on board, and we'll not quote you on it, but next year at scale we'll hopefully see some of that stuff progressing.
You probably will quote me on that, but
yeah.
Also I should have said we've got templates for those work streams, and so within 2 weeks we'll have the detail of what each of those 13 areas is covering with a view, and that's what we intend to publish by the end of June. So
Great.
you'll
And
be able to
just
scrutinise that.
on the work streams as well, the work stream around the sickness absence reduction. So I know that's a big, obviously, issue impacting on the health service and impacting on finances. But see, just in all the conversations that we're having around those issues with the cardiac unit in the Belfast Trust, I have no doubt that, and especially if we're talking about a culture of bullying across all the trusts, I have no doubt that those levels of sickness, I'm sure, is feeding into some of that. So I think the sooner we deal with even the broader issue of the duty of candour stuff, obviously the immediate issues around the cardiac team, but that is bound to be having an impact on staff taking sickness, and then that's having an impact on the staffing levels that you have to treat patients, and then all your issues around your finances. So hopefully again some of that work will help with those bigger issues. And my final question was around the income generation stream. So again, Mike, you referenced the work around the life sciences. It's mentioning looking into all island funding, but Minister, this question is for you. Is there any specific work that's being done? And I know obviously the Minister of Finance has the overall remit with funding from the British Government, but we've had these conversations previously in the Health Committee and in the Chamber, see around the British Government, and you were saying about trying to make the special case, particularly for our high levels of mental illness and ill health. Is there a case, is there still any work that yourself and your new Permanent Secretary can undertake to try and press that on the British government in terms of our special case, why we would need additional funding?
Well, I have made that case to the Secretary of State on multiple occasions. I've made the case to the Prime Minister, Stammer. I don't think it's landing, if I'm going to be honest with you. I think they understand the logic of it. And to my mind, the beauty of it, as it were, that's probably the wrong expression because we're talking about mental health, but why it is a strong case is that the legacy issue of poor mental health coming out of what we so euphemistically call the Troubles is a public health issue in Northern Ireland, but it's not in Scotland, it's not in England, it's not in Wales. Yes, there are people in those countries who are suffering poor mental health as a result of the conflict, but it's not a public health issue. For us, it is a public health issue. So if you invest in that here, there's no Barnett consequential, there's no repercussive desire or need to spend money on the same thing in the other 3 countries of the United Kingdom. I think that's a compelling argument. But it is certainly not landing in a way that people are coming back from Downing Street or the Department of Health and Social Care in London and saying, tell me more. And that is a matter of regret, but I will not stop pushing it because it's a fact. And you know, if you take a hotspot map of the Troubles and then superimpose a contemporaneous map of mental health issues, you've got a match, like North Belfast.
Thank you. Alan Robinson.
Thanks, Chair. Thanks, Minister, and thank you, Mike. It is very good to finally meet you. I think, like others, in my very short time as an MLA, I think I was aghast, and it is the bombshell moment when we heard about the cardiac surgical unit. And I know seasoned performers in this building who have been here for quite some years were absolutely aghast. It is right up there as probably one of the poorest news items that was ever broken. I suppose that leads me on to ask, you had intimated there, Minister, that you possibly expect that there may be other potential stories that may break. And I suppose, could I ask then for a commitment from you that in advance of your knowledge or your department's knowledge, that can you bring that to the floor of the chamber rather than the other way around, where it is by way of oral urgent question? Because I don't think any of us want to bring you into a chamber and pose gotcha questions at you. I don't think it's the right way to do government. I think it is much better that if you show your hand to us, for us to scrutinise it. I mean, I think, and it was, someone described it to me that what happened at the surgical unit, and certainly the news items, it was more akin to something that you would see in a Wild West bar rather than a surgical unit, particularly a key surgical unit, one that is so important to people's livelihoods across this province. So I do hope that you can give a commitment that you will show your hand when, I hope it doesn't happen, that there may be other cases, other instances. And I suppose, I think those that come to this committee and present with a contrary view to a duty of candour, I think that now does demolish that. It demolishes it, as far as I'm concerned. The other question, Minister, could I ask a very localised question? Causeway Hospital, you know, you and I have spoke about it, I've raised it multiple times. It is now, I believe, either in your entry or it is heading for your entry. When do you expect to make a decision? And can I ask you very politely, can I ask you to make the decision based upon the facts? Drill down into those facts, drill down into how they're going to deal with the bed pressures currently in Antrim, how they're going to deal with ambulance provision, which is well documented, the pressures that will be upon Antrim Area Hospital, the subsequent pressures that may fall to Altnagalvin Area Hospital, and the potential, as some former surgeons have said, may well kick away a key pillar of Causeway Hospital. So I do ask you, and I plead with you, to look at that one, look at the facts.
Okay. So in order, I make the commitment as soon as I'm aware. I don't want to sit on bad information, because that makes it worse, and we know that. So, yeah, I give you the commitment. As soon as I'm aware, I will be instructing officials to make it possible for me, whether it's in the House or whatever, to get that information out. In terms of the specific with regard to the causeway, yes, the Northern have now made their recommendation. It has gone to the SPPG in my department for assessment, so it is en route to me. It has not arrived yet. The decision I make has to be made on clinical safety grounds. Is it going to deliver better outcomes, and what is the downside? And you've enumerated some of the potential downsides. Has the Antrim Area Hospital got the bed space? Has it got the capacity? Has it got the workforce to look after this? And does the ambulance service, do we have the transportation that will be required if we're going to do this transfer of emergency general surgery? So, absolutely. We're not there yet. We're obviously heading in a certain direction. But I have to make the final call. And I don't want to make a bad call. I don't want to make a call that delivers worse outcomes for anybody.
Either to the 1,415 people who responded to consultation. Thank you.
Okay, thank you.
Thanks, Mr. Chairman. I have a question for the Permanent Secretary and one for the Health Minister, so I'll ask the both of them together to speed things along. Mike, you're very welcome in the post, and I know that you have extensive health experience in England. I'm just wondering, are there any learnings there that you would hope to maybe see rolled out in Northern Ireland? And it's really an unfair question, is because you're so short in post, you're probably still struggling to find your way around Castle Building. But could I ask, what are your initial views on the timescale to get our health and social care system to where we want it to be? I mean, I've heard figures like 5 years kicked about and 10 years. So just what would your initial views be? And what can we as politicians do to help expedite that process? And my question and comment to the Health Minister would be, I certainly welcome last week the swift action that you took, Minister, in accepting the Pay Review Board recommendations, and I understand now that is gone up the line to the Executive for a final decision hopefully will be made. But if we can't find a budget to deliver those recommendations, how damaging would be the potential industrial action that would flow from that, and how would it limit the efforts currently been undertaken to deliver the improvements in waiting times? And in relation, I wasn't going to mention GB practice, but I feel I have to ask this question in view of remarks that were asked by a questioner earlier. In terms of, we talked about this one pager where you asked for information about how this £80 million was going to be spent, and certainly when I asked questions last week to the BMA, it was very vague. Would it have been reasonable for your department to have been presented with a costed business case to support that £80 million ask? Thank you.
So very, very quickly, I'm conscious of time. Look, we can start making progress now. I think we have some assets that England in particular doesn't have. We have a scale where we can get our arms around it, so all the chief executives I can get round a table and we can agree a strategy. Our clinical colleagues, I think, have been looking for support and leadership around some of the change agenda, and we have some very exciting bits. So I'm very confident that if we can get through our short-term issues, which are largely financial, I wish I had got a growth budget, because then I could really motor, but we're going to use the financial challenge as a catalyst for change. I think I would be saying to you that by the time the current mandate is served and people go into the next election, that you should be able to see significant impact on waiting times, that we're starting to put in place the demand management model, that we've made improvements on culture that have been revealed as a big issue for us to tackle. Culture doesn't change overnight, as you know, but actually we need to lay a platform for that. And also, just one thing I've not had a chance to say that I will do, is that we need to invest in our leadership capability. And I think we perhaps underinvested 5-10 years ago. And really what we need to make sure is that every job that comes up in Northern Ireland, we have 4 or 5 people, talented people, yes, test against international opposition, but I think coming through our system, wanting to take on those leadership roles, and really capable of taking this vision forward to delivery. So I would say look for improvements in the short term, although this year's tough, but by the time we get to the next election here, we should be able to see genuine improvements. And I know that's where the Minister's coming from. And he said to me, I said to him, what's the first thing you want me to do? And he said, urgency. So I really appreciate the position that I have in terms of the pressure.
And we both, hopefully, touch wood, be here for a couple of years. And the idea is to try and set a direction of travel that the next Minister feels compelled to follow, because then you'll get a whole mandate on top of this 2 years, and then you really will see differences. In terms of the pay, I mean, I sat with the unions last year. I said I want this to be the last year when you have to wait until the 12th and final month of the financial year for certainty about whether you're getting pay parity. So I have honoured the commitment now that the recommendations have been made public of saying I want to do that. This is taking us down the route of the ministerial direction, which is not an event. It is a process, and that process has a way to run. In terms of the implications, given what I heard about last year, which included one body saying 1 penny less than parity and it's industrial action, I think we have to assume that if we don't deliver, that there will be industrial action, and that industrial action will have an impact on our healthcare delivery, not least in terms of tackling those waiting lists. Your other point about the one-pager becoming a sort of fully costed business plan, sometimes I think we put too much effort into promoting an idea when the best thing to do is say, here's my idea, what do you think? Because if the answer is no, there's absolutely no point wasting a lot of time and resource, fleshing it out, costing it, talking to people. And I think, sometimes, like when we're talking to the Shared Island unit, which we are doing, I think it's better to do the kind of one-pager, because sometimes they come back, for example, on the mother and baby unit, it was a no when we were doing it ourselves, and that's fair enough. But there's no point doing all that really intensive, detailed work if you're going to get a hard no. So the one-pager was all I was looking for. Chair.
Minister, just before you go, bad news day for you. Yesterday you opened 2 excellent centres, the Fire and Rescue Service that we were at, excellent, and the Regional Cancer Therapeutic Treatment in Enniskillen. Can I just ask, because I need to ask it in terms of the 85 million ring fence for red flag cancer, in a time-critical treatment, can you give us a sense just before you go when you expect to see those targets reduced, and how soon do patients expect to see benefits and delivery on that?
Well, what I can say, Chair, is that I'm hoping before the day is out to sign off on the more detailed plan that I promised on the waiting lists generally, which I promised by the end of this month, and I'm hoping to sign that off, I say, hopefully later this afternoon. I have a couple of meetings to go to now, but after that, and that should give you some more detail on red flag, but the whole kind of £215 million package. The 10 million on the waiting list reimbursement scheme, that goes live on Monday.
And before you go, just want to thank you all for coming. David, this is going to be the easiest meeting you're ever going to have in front of us. It was about budget, and we appreciate the fact that very few of our questions
he was
were
my
budget.
backstop, so
okay, thank you very much.
Thank you.
Okay, members, thank you. Obviously, we could have kept the Minister for an hour and still not got through half the issues that we needed to raise with him, so I appreciate that was difficult. Yes, Linda?
Just, I think that he did pick it up from Ursula, so he may well be going to respond in writing, but just to be sure, can the committee write and ask under the Systems Financial Management Board, what are those? The Minister outlined they had established a number of actions. What are the actions, and what are the expected outcomes of those actions?
Okay. Yep.
Chair, could I ask? So the Minister, I think, in some ways sidestepped our issues around the trust. Could I ask that we invite the trust to give evidence to us on this particular issue, and perhaps on the wider issue of what they're doing to prevent this ever happening again, because I do think it is appalling that particularly junior staff were treated in the way that they were. And I think it is worthwhile asking the Trust to present us with evidence around that.
Yeah,
When do we expect all the trusts?
I mean, we probably need to see at least the very recommendations or action plan. I mean, we need to see that probably. I don't know if we need to see that first, but I think we should certainly invite them to.
I think the Minister indicated that was in the ether.
Well,
if
he
not
said
particularly.
he said it needed legal advice with regard to the actual report. You know, he may come back with something somewhere in relation to the.
Publish the recommendations.
But I think he can publish the
When are the
recommendations.
5 trusts next up?
Do you know? Or?
Just to say, Chair, we talked about bringing the trust up individually from the new year rather than all together.
I think that's
We plan to schedule that from September onwards, just depending on timing. But the plan was rather than the 5 or 6 trusts coming together, that we would do separate sessions with each of them.
Your proposals for a specific meeting with the Belfast Trust on a specific issue?
In my head, I think that's would be something. I don't think many of us will ever have experienced reports
It was atrocious.
that actually relay that type of information. And clearly the Trust, I mean, the Minister is saying that the Trust are the people who manage this, they're the people who are responsible, and I think that probably they should be coming and telling us what they've done.
Chairman, if I could just maybe express a bit of caution on that course of action. There may be 1 or 2 of us in the room here who have had the benefit of actually having a copy of the report. However they got that, I don't know. You've said yourself you haven't seen the report yet. So I think it would be a bit premature to bring the Trust here to discuss a report that none of us have seen. And I think certainly I agree with the concept of bringing them and putting them through the hoop on it. But until we know what's in that report formally and not sort of by third hand, you know, I think it might be a pointless exercise. I think it would be more, but I absolutely agree they should be brought here and held accountable, but not until we have seen the report.
Linda?
Just given some of the conversation, it should be the chair of the trust as well as the chief executive, and I know that they have before brought chair up, but not always. So I do think that I would probably like to see the report too, but I'm not. I'll go with whatever the view of the committee is.
I think Alan actually made a good suggestion, but I know in previous scenarios like this, because some members obviously have seen the report. I haven't. The media have obviously seen the report. The report on it. It might be, in essence, a question that we could ask if the report isn't going to be published. Hopefully it will. But there are circumstances where committee members have seen reports in a confidential setting where we can read the report and it allows us to have that information. So I think that's maybe a halfway house if there's a scenario that we actually see the report and get the trust.
Maybe those that have it could share it with the rest of us.
I think mine is probably more sensible. So, can we maybe take that suggestion forward if people are happy that first of all, we've asked for it to be reported publicly, and that's what we ultimately want. If the department have a concern, then can we ask that at the very least committee members in some kind of confidential setting can get access to the report, and then we bring the trust up. Fair enough? Okay.
Sorry, Chair.
Go ahead, Danny.
Just on a quick one, just in regards to the maternity decision, the Minister said there that the decision is imminent.
Yep.
I think we were told previously it was going to be taken over Easter, so it does seem a bit on the late side, but could we ask the Belfast Trust, just as soon as that decision is made, that we're informed of what it is, the current cost projections and the timeline to opening?
I think we were told imminent the day we visited it.
Easter.
That was a long time ago. We were told it was imminent, so I don't know. Yeah.
Sorry, Chair, can I just add? I just noticed in the Minister's paper that he is returning 17 million in terms of flagship projects, and really mentioned the Children's Hospital and the maternity unit. If he is returning money in this unit, could we also ask who's paying for the repair work that will need to be done at the maternity hospital?
mean, the unfortunate thing about the last 2 days of media, we weren't able to ask the Minister the questions on the budget that we probably wanted to in advance of the last 2 days, so no, fair enough. Okay, so Dan, or Colin?
Yeah, sorry, Chair. Can I just, I want to follow up with what Linda said, maybe just to support her on it. I don't know if we've really drilled down that. Is that it's the trust board, it's the trust chair that we bring up, because that board has been in place while there's been quite a number of the issues that we've had to deal with in this committee. And there's only an interim chief executive that may or may not be the chief executive come the sort of September time. So I think it does need to be them. And also in terms of the not getting to ask about the finance, I don't know if there's an opportunity maybe for another scheduled opportunity to discuss that, but I know one thing that jumped out at me was I think a reference that they have 1 point something billion of a backlog of maintenance across the health estate. I mean, I know there is a big health estate, but that seems like a huge amount of money that is never going to be ever met in terms of financial contributions, but there's obviously a lot of work that needs done. Could we get a breakdown of what that 1 point something billion is, and just where the works need to be done?
Yep, we can certainly ask. Okay, everybody happy? Okay, so we'll move on then to item number 6. You want to go back? Okay, we'll go back then, sorry. So, Chair's business. Feels a bit. So, can I just thank the Pharmaceutical Society for attending an informal meeting with the committee on Tuesday. I unfortunately wasn't able to attend. I had another event in the Long Gallery, but members did have the opportunity to meet with the Society's chair and the new CEO and received an update on the proposed rise in annual retention fees. We're going to consider that issue further in the coming weeks via a statutory rule. Also, just to advise members, the committee has set aside Thursday the 12th of June to hear oral evidence from those with lived experience for the inquiry. The clerk is working with Voices for Care and Macmillan Cancer Experience panel. Committee, we're going to hold a short forum in the Long Gallery from 11:30, lunch at 1 p.m. 2 witnesses who are actually in active cancer treatment and have palliative care teams have agreed to attend the committee meeting that day. That attendance obviously, of course, will depend on how they are on the day. So just it's important that all members advise on their attendance for the morning of the 12th of June. Hansard will attend and there will be an audio recording of the forum, so it's an important meeting. So can everybody just let the committee staff know? Item number 3 then, draft minutes. Draft minutes to the meeting held on 22nd of May are at page 6. Everybody content of them as drafted? Yep, thank you. Any matters arising? None? Okay. Okay, so we're going to move then to item number 8, which is the Research and Information Service, RAISE, papers on the inquiry into access to palliative care services. So can I just refer members to the 2 RAISE papers at tab 8, the Economics of Palliative and End-of-Life Care at page 92, and Future Needs and Emerging Trends in Palliative and End-of-Life Care, and that's at page 133. Just to let you know, we're going to schedule briefings on these papers in the coming weeks. And then item number 9, Human Trafficking and Exploitation SR. So can I refer members to papers at tab 9? So there's a clerk's memo at 163, an SL5 at 165. The SR itself is at page 167 and an explanatory memorandum is at page 169. There's also the report from the Examiner of Statutory Rules in our table papers at page 59. So this SR will remove requirement for 5 years post-qualifying social work experience in order for a person to be eligible for appointment as an independent guardian, and introduce a new eligibility requirement that the person must have completed their post-qualification period of assessed employment, which is 1 year. So this has come before us. So we did receive a detailed oral briefing by officials on the 3rd of April on the SL1 and we were content with the merits of the policy proposals. There's been no change to the policy content since then. So can I just also advise the members that the Examiner of Statutory Rule has reported on the technical aspects of the SR and has no issues. Are we content with the SR, members? Okay, well then formally then I'm going to just say that the Committee for Health has considered SR 2025/83, the Human Trafficking and Exploitation Criminal Justice and Support for Victims, Independent Guardian Amendment Regulations NI 2025 and has no objections to the rule. Okay, number 10 on our agenda is the written briefing on update on substance use strategy, preventing harm, empowering recovery 2024-2028. Can I just refer everybody to papers at tab 10, and this includes a written briefing providing a summary progress update. So do members have any comments on it? None. Okay. Correspondence, item number 11. So can I just refer members to a correspondence index in the main pack, page 266, and table papers, page 11. So within that, there's a letter from research for AGNI, and it refers to correspondence from AGNI, and this is page 304 in our pack, on research that the Frailty Network has commissioned AGNI to undertake in regards to the experiences of older people during and after an unplanned stay in hospital. Can I just ask if members are content that the committee responds to AGNI to welcome the study and agree to support its launch with a photograph up here in Parliament buildings? Yeah. We all love a good photo, and that's very worthwhile research, so I think that's important. Also then, can I just refer the Minister's statement in relation to the issue Linda raised. It's correspondence from the Minister, it's at page 12, to a request by Linda in plenary that the committee be provided with information on 10 projects awarded funding under the Peace Plus programme and a copy of the Child Protection Work Programme agreed by the North-South Ministerial Programme. So it's there. Linda, do you have any comments, or any other members have any comments?
No, I might do follow up on it, but...
Okay. Okay, thank you. Then just again, members of the BDA, British Dental Association, there's correspondence to the First Minister and Deputy First Minister on dental access. If any member have any comments? None. Okay, are members content with the rest of the suggested actions in the correspondence indexes?
Just on the BDA, we've obviously, there's been a bit of update on the other, like the core kind of funding and stuff for them, but I'm assuming that with all of the DDRB recommendations and the issues on back pay, I just unclear with the response today that they are sorted. So will he respond to us and copy us in as well if the committee has been copied into this one?
We would certainly be asking the department that the suggested actions was that we would be copied into any response
great, yeah.
to VDA.
Yeah.
Hi. Alan, were you looking at him?
Nope.
No. Okay. I mean, the other thing that I noted was the correspondence between Communities Pharmacy, ANI, and the department. So I think we'll all keep an eye on that correspondence and where it ends up as well. Okay, forward work programme members, draft forward work programme, page 359. So we are meeting with them, meet with the members, which is ourselves, informal event on Tuesday at 1 p.m. in room 21. Again, please advise of your attendance to the meeting if you haven't already done so. It's important that we know who you all is coming. And also, if members are content to note the rest of the briefings set out in the forward work programme. Any other business? None? Okay. Okay, we have went through everything else. We're kind of, we're okay, fair enough. So we're moving back now to item number 6, which is an oral briefing from the Royal College of GPs. And can I refer members to your papers at tab 6, and that includes a briefing paper from the college, and that's at page 3 of table papers. And can I just welcome to the committee Dr. Ursula Mason, who's the chair, and also Dr. Emma Murtagh, vice chair of policy. So you're very, very welcome. And we apologise for shifting the time in terms of that. You'll understand we were meeting with the minister, and obviously GPs was a big focus of that conversation. So it's kind of timely that you have. So I'm just going to hand over to yourselves to make any kind of opening comment that you may have in relation to our inquiry into palliative care, and then we'll take questions from members thereafter. So over to yourselves.
Thank you very much, Chair. Good afternoon, and thank you for the opportunity to present some oral evidence today. I'm Ursula Mason, a GP from Carryduff in County Down, and I'm Chair of the Royal College of GPs in Northern Ireland, and I'll let my colleague Emma introduce herself.
I'm Emma Murtagh. I'm a GP in East Belfast and I'm the Vice Chair for Policy of RCGP-NI.
Time, space, capacity and capability. These are all the things that you would want your GP to have in ample supply whenever you or a loved one need palliative or end-of-life care. GPs are an integral part of the delivery of palliative care for our patients, embedded within our communities with intimate knowledge of our patients, their family and their life journeys. Often we are with them for their diagnosis that has led to palliation, supporting them through treatments up to the point where curative care is no longer possible, and then helping them to live better through symptom control towards the end of their life. It's important to state that generalist palliative care is a core role for GPs, and there is good reason behind the continued use of the adage, from cradle to grave. You will have heard from many of my colleagues right across the health and social care system who've presented on the role of generalist and specialist palliative care provision, and I am not going to repeat much of what they've said, nor will I go into great detail about what palliative care is and what we deliver for patients, because you will know that already. I want to give you the opportunity to ask us questions today about our experiences and the challenges that we have, much of which we've set out in our briefing paper. I want you to ask us about why our continuity of care and knowledge of the patient is so important, but also about our worries about the impact of the crisis in general practice and what that's doing to our workforce, our workload, and ultimately our ability to deliver a quality and safe service for patients. To ask us about the challenges around prescribing of palliative and end-of-life medication and the impact of the fragmentation of IT systems, as well as the geographical differences in care delivery. But before I finish, and as Emma and I get ready to answer your questions, I would like to ask you all too. Don't worry, I'm not expecting you to answer them. I know how this works. We answer the questions and you ask them. But I've just got two for you today. I would like you to think about a time when you have been present towards the end of life of a loved one and reflect on the care that they received. Was it a long time ago or more recently? Were there good experiences or not so good? What made a real difference in their journey, or indeed yours, in how you considered the passing of that loved one? I want to also ask you about whether you've had discussions with those that you love about what the future might hold for you should something happen, and what your wishes and considerations might be around not just the care that you get, but how you live your final weeks and months. Not surprisingly, I'm asking you about advanced care planning, and I hope that you might want to ask us about that too. For now and for the future, the policy that was launched in 2022 is yet to be enacted. We've lost almost 3 years of opportunity to make a difference in how we consider and deliver care towards the end of all our lives. And we need to get on and deliver this, ensuring that conversations and the resulting actions around our wishes are normal practice in our day-to-day lives. Thank you for your time today. I'm happy to take questions.
Thank you. My mother passed away in 2004 in terms of your question one, and I mean the care that she got from her GP, from the nurses and from the community nurses was excellent, and that added to that very sad experience in terms of the care that my mother got and the experience of us watching her pass away. I've had no discussions yet, but maybe this evening over dinner. So I really appreciate you coming before us. Obviously, GPs. This is a specific inquiry that we're having, but we've focused a lot in the last number of weeks with regard to GPs and funding, etc. So it might be useful just at the outset from both of you to get a sense of issues like workforce shortages, burnout, contract handbacks in general practice specifically affecting the and how that's affecting the delivery of palliative and end of care, which I think I'm correct in. Last week when Francis said that 95% of palliative care is carried out by GPs.
Yeah, so I think you've said that correctly. It's a core role of general practice, and we very much value the role that we have in our patients' lives towards the end of their life. One of our challenges is that we've got to be able to do that as well as everything else. And you'll be well versed in the challenges that we have around access in terms of care delivery right across the population. And we've got to carve out time in our day-to-day work to be able to provide that timely response to palliative requests and concerns from patients. One of the things that I've seen over the last number of years, and we think about our sort of full day, and I've talked before about, we need to be able to provide urgent and unscheduled care to our patients. We need to be able to provide preventative and proactive care, chronic disease management, and obviously the aspects of palliative care. And it's how you fit those all into your day and how you prioritise them. So there are some things that we absolutely have to prioritise, and palliative care is one of them. So for most of my patients, if I've got a list of 20, 30 patients to see and there's a request for a palliative consultation or a query or whatever that might be, GPs just down tools and they deal with that because they recognise the importance of their role in the delivery of good quality palliative care. But that has a knock-on effect, and the challenges that we have in terms of workforce and funding and the delivery of core funding into general practice and the resulting instability will have an impact because there are only so many hours in the day, there are only so many GPs, and there are only so many actions that we can take safely in any one day. So the landscape and the position that we find ourselves in means that we're constrained in our ability to deliver for all our patients. But I can say that if you are a patient with a palliative care need, or if you are getting towards the end of life, your GP will prioritise that. It's the knock-on effect that it has on the rest of your workload. The other thing I think is important to comment on is that, we are often trying to be proactive, strangely enough, when it comes to palliative care, because we recognise that as people get towards the end of their life, their needs change, and we've got to be able to be there when we can. And so some practices and some GPs will often give their telephone number to a family when they're not working or they're not on call or they're not there, and that's relatively commonplace. And those things matter to families, because the other thing to remember is that we not only care for our patients, we are often the GP for the husband or the wife or the children or the grandchildren, and we follow their journey, and our journey, that journey goes on beyond the passing of a loved one, and knowing what has happened in those environments, in those situations, are really key to be able to deliver good quality care for our patients beyond the passing of that loved one. Have you got anything else?
I mean, being a GP and delivering palliative care to a patient is, I think without doubt, it probably is the biggest privilege that I've ever had as a GP and that I will have. It is challenging because they're really emotive things. You're sometimes dealing with young people, and also because you have the context of what this means to that family. I mean, when I think of the last patient that I dealt with palliative care, I know the family inside out. I look after many of the family members. I had seen the disease from its start to its end. I had seen similar disease in other family members, and I knew all the context. So it actually makes it a privilege, but it also makes it quite challenging because you're carrying this all on your shoulders, which need to be broad. But just from what Ursula said, I mean, we will down tools, we will go, we will sit. It all takes time. Certainly the prescribing and the coordination, which is a lot of what we do, takes time. But the sitting down on the bed with the patient and explaining to them what their last weeks and days are going to be like is so important, and that can't be done in 5 minutes or 10 minutes. That takes an hour, it might take an hour and a half, and by the time you get back to surgery, you sort out the prescriptions, you maybe speak to a district nurse, you speak to a community team, and then you're suddenly 2 hours behind, and everyone else is still waiting. So we need time to do it right, and you get one chance at this, you get one chance at good palliative care, and it has to be done correctly, but it is the knock-on that it will have on other things, which I am concerned about.
That's a very good point. One chance. Danny?
Thank you, Chair. I declare an interest just as a nurse who has previously delivered palliative care within a hospital setting, and certainly I've seen the huge benefits to patients who've been suffering incredibly and been able to be made comfortable in those final days and final hours of their lives. And it is, as you mentioned, it's a privilege to be there and to be part of that. And it does have a massive impact on the family, and that those are the ones that are left behind with the memories of that time. So knowing that a loved one is comfortable when they pass, is a huge, huge comfort to those families. Palliative care is absolutely vitally important. I wanted to pick up on a couple of things. In your report, you mentioned geographic inequalities, and it was something that you asked us to ask about. You mentioned 2 patients with the same GP service, but in different trusts, having different experiences. Could you just broaden that out a wee bit for us?
Yeah, so that can happen relatively frequently. I mean, if you think about the provision of palliative services right across Northern Ireland, even something as simple as the fact that, well, we could start with the basics in that, you know, one GP practice could be really unstable and not have very much GP provision, or it might have handed back their contract and is being run by locums, and they're being asked to deliver the same type of service to a practice that's maybe well doctored in an area where they've got good provision. And then we think about district nursing services. So not everywhere across Northern Ireland has a 24/7 district nursing service. So the ability to respond in a timely manner to someone who's perhaps needing end-of-life medication in an out-of-hours setting may be different. And also then that the ability for GPs to refer for specialist palliative care provision is different across the trusts. So what we often find is that while on paper it feels like all of those things should be there, or in some shape or form they're there, it's not universal. And I think we would love to see the ability for this to be universal right across the board, not least for someone like me, because in my practice 2/3 of my patients live within the Belfast Trust boundary and 1/3 live within South Eastern Trust, and there are many GPs like me where our patients cross 2 boundaries. And the mechanisms and referral and the people that we talk to and the services that they get, there are nuanced differences, and I need to know what they are. And if they were all the same, it would be so much easier. Because ultimately, it doesn't matter whether you're in Castlederg or Castlewellan. Technically, we should all be getting, or we should all be striving to deliver the same service. And that doesn't matter whether it's a district nursing service, a GP service, or a specialist palliative care service. We should be able to do the same for all our patients.
I think also when there's a difference between the services at one, you know, and a lot of it also is because a lot of these services are delivered by charities. There can be significant differences when they're not trust-led, and there is a danger that there, certainly as a GP, that there are services there that I don't know about and that a patient could have availed of, but because I didn't know about it, I didn't refer to. And certainly I'm the same. A lot of my patients are South Eastern Trust, a lot of them are Belfast, and even just the very simple ways of how do you refer can be different. Now there has been a lot of work done in Belfast recently, and there's now one pathway and one mechanism for referral, which is excellent. It's so joined up, and hopefully we can continue in that same vein.
Just a second question, one thing that we've heard time and time again, and it relates to your second question, just about having those conversations with people and how important it is about advanced care planning to know, you know, what a person's wishes are in their final days, and you know how they want to be cared for and where they want to be cared for. One thing that we've heard time and time again is the issue with DNA CPR orders that seem to stop when they leave hospital. In fact, they continue in an ambulance and then they stop when a patient gets home. How do we join that up? How do you see that as a solution?
So there's a really easy way to do that, and that's to enact this, which is now and for the future, advanced care planning. So part of this, it's not just about DNA CPR, and it's not just about asking about last wishes around clinical care. It's about the whole of life. It's about your financial situation, your social situation, from a legal perspective. So it encompasses everything, but obviously clinical is one big part of it. And part of that's about having conversations about what you would like to happen at a time when you maybe aren't able to make those decisions for yourself. So you're thinking about the future, you're talking to family, you're writing it down, and you're saying to people, this is what I want and need when the time comes. And you can have those conversations at any stage. We should all be having them, and we culturally need to move in Northern Ireland to a position where that becomes the norm. It's not just whenever you get a diagnosis of something really nasty and you know that that's going to, you know, the end is in sight. This is about what we talk about, what we think about, and what's important, and making those wishes known to those around us that love us and can enact those for us whenever the time comes. But Part of that is respect, which is a document which would encompass DNA CPR. And you're absolutely right, it stops at the point where you transition from one to another, and that can be from an ambulance to a trust, from one trust to another, and obviously from secondary care services back into primary care. And it's a bit silly to think that in this day and age we've got to keep doing this and got to keep having these conversations with families. Because can you imagine, as a family member with a loved one who has lost the capacity, and you're having a conversation around best interests, about what they might have wanted, and you've not had that conversation, and you feel the burden of that upon you, and you're kind of thinking, well, what would they want? What do I think they want? What do I want? You know, and those are really difficult conversations. But imagine having to have those in the emergency department, or before that in the ambulance. And then you come out of hospital and somebody else has a conversation with you. And then the GP arrives and they have a conversation with you as well. And it must get very difficult for family members of loved ones or individuals themselves. So respect is a document that would travel with the patient, that would be a single document that would sit right across the region. It wouldn't matter where you were. And it outlines your wishes, as well as, you know, and that's about treatment, but also about CPR. And about that decision to say, look, I don't want CPR to be enacted in the event that my heart stops, you know. And it's a much bigger thing than just CPR, but it would encompass a lot of what we need to do to actually make that seamless for patients. Remembering that it's a live thing and can be changed and could be flexible, and you don't have to sort of say, well, if I've made my decision now, that's it, I can't change my mind, because these things can be, and it's important that that's sort of communicated as well. So if we could roll this out, enact it, deliver it, it would make such a difference to many, many people. It would make a difference to individuals who are reaching end of life. It would make a difference to family members, but it would also make a difference to you and I, about thinking that at least if I've got that, if I've had that conversation, I know that my wishes will be respected insofar as they can be, depending on the circumstances.
Yeah, absolutely, and I can see that. I find it amazing that it hasn't been done already, and I have seen circumstances where people are being distressed by having that conversation again and again, and you'll actually be removing the burden of making a decision, you know, a family member having to make a decision on your behalf, not knowing what you want.
Absolutely.
You know, which is an incredibly stressful thing to have to do.
Yeah.
No, thank you, Chair.
Thank you. Linda?
Thank you, Chair. And you've answered actually a lot of what I suppose I was going to ask you, Ursula, to be honest. And the answer is, to your questions, is yes, and I'm not going to talk about it, or I'm going to become as known as the Assembly Crier. But it makes a massive difference to a family when you know that the person is having the end-of-life experience that they would want and that you want for them. And it's not even at that time, it is the post-death trauma. So I've also spoken to people who have not been so lucky, and we're going to be speaking to people with lived experience, and I'm sure we'll hear a bit about that, who haven't had that, you know, the person they love has not had the end-of-life experience, and they have not had the end-of-life experience with them that they would like to have had. So, and the post-death trauma that causes is just insurmountable. In some cases, it's you know, it lasts their whole lifetime and impacts them their whole lifetime. What I do want to ask, I suppose, is what could help GPs? So, you know, a lot of what we have heard about is around the model of funding for hospice, you know, things like that. So in terms of the additional work they could do in the community, if there was better funding for the core services that the hospice delivers. So because not all of this needs to be delivered obviously by GPs, so there's stuff, what do you think would immediately be of assistance? Would it be having, instead of the postcode lottery around what services in what area, because when you talk about the difference in trusts, a lot of that is because we don't have statutory core funding for hospice services, or for, you know, hospital to home services, whatever we want that model to look like. So is there something that you could point and say, this would help us to help our patients? So if we were able to say, at the end of your life, rather than calling me hoping I'm going to be able to leave surgery and come to you, this is something that will, and I'm not saying that this is to replace, because there are things that just cannot be done by anybody else, and we need you to be able to do those things, but we probably need you not to be called out of surgery to do the things that there are other services there to do.
You know, I would have to say, I feel that a GP is really well placed to do palliative care for all the reasons that we've
A
discussed,
GP what, sorry?
is really well placed to do palliative care,
Okay.
and I feel that that is a core part of our work. So probably where I would come from it would be to say there are other things that we do that other people could do, but palliative care would be the thing, or one of the things that I would want to keep. I don't know if you agree with that, Ursula, but that most certainly is what I would feel.
Absolutely. I mean, I think it's what we want to be able to do is provide a seamless care for patients when they need it. And I think the position that we find ourselves within the community, and for the reasons that we talked about, our knowledge of the patient and our knowledge of their family and their situation, that does put us in a position whereby we probably can deliver really well for patients, but our challenges are in the other bits that we're not necessarily doing. I think there is something though, and you talked about sort of the core role of our colleagues in hospice and within specialist palliative care provision. More and more people are going to die because we have more and more people living longer with complex conditions, and our population is growing. So we know that the need for palliative care will increase over the next decade, probably quite significantly when we look at the figures. But what we also know is that all of those people do not need specialist palliative care provision. Most of them just need generalist palliative care provision. And I know one of the remits here is to look at, well, what's the state of play across specialist palliative care. I suppose my argument would be, actually, it's really important to count and measure all of the palliative care, so the stuff that's happening in a general setting, the people that just the GP and the district nurse see, because that's all they need. Because it's going to take everyone to be able to deliver really good quality palliative care, but what we need to do is join the dots up between those of us who are doing it at a generalist level and obviously the specialist services as well.
See, in terms of, sorry to interrupt you, but in terms of Linda's question about what could be done to help, and your answer about GPs being in a lot of cases better placed than others, so what help could we do for GPs to allow them to do that better?
So the reality is, I mean, we talked about it when you asked my question about the challenges of where we find ourselves. So we have a general practice service that is unstable, at crisis, and underfunded, and that's the simple thing that could be done to. So if we had a stable, secure, well-funded, well-resourced, and with a workforce that was fit for purpose, we could deliver more, and we would be able to deliver more. So we will always down tools, and we will always go and do that because it's a really important role of a GP. But if there were more of us, the knock-on effect on the other patients wouldn't be as severe. So I wouldn't have to apologise to someone because I'm 2 hours late and say, I'm really sorry, I had to go and see. And I mean, our patients really understand that. If I say to someone, I'm sorry, I'm delayed because I was seeing a palliative care patient, there are no arguments because people understand the importance of this. You know, communities really value good quality palliative care. But there is, I think we need to make sure that we have a stable service. And the worry is that the more unstable we become, the less able we are to deliver. And then we find ourselves in the difficult situation where our core role, because again, this is about the core of what GPs do from cradle to grave. If you start to undermine that, then you really take away from us what exactly we are within our communities and what we're delivering. So I would say stabilise. There are bits that we could do that make joined up working a wee bit easier, in the referral processes and the IT systems and all of those things. And actually, and I know my colleagues in palliative care will say, strengthen their workforce, more of them. You know, we will need more of everyone. This is not a them and us kind of situation. This is a, can we make the provision across generalist and specialist something which fits well together, that communicates well together, the interfaces are smooth, the transitions are smooth, and that patients get what they need when they need it. So if you need specialist care, you get it in a timely fashion, but that actually when that's done and you can move back into a generalist setting, those transitions are smoother and you know, joined up. I mean, the whole aspect of even prescribing, because at the moment, one of our roles is that, you know, we're often called on by the specialist teams to prescribe in a general setting because they don't or can't because of the way the pathways work and the mechanisms. So we're often in a position where someone's in a specialist setting and they're moving out maybe from hospice into community, or they've been in community, but as that key person who is standing over and writing those prescriptions, there's something integral about what we have to do, and we do need to make sure that the links between ourselves and our district nursing colleagues and ourselves and the specialist providers are as robust as they can possibly be. So fix our core. That would fix an awful lot. Yeah.
And also, just to say a word on prescribing, I mean, we've talked about e-prescribing for so long, but electronic prescribing would make a major difference in palliation, because so many times I have written a prescription in a patient's house for injectable medications for a syringe driver, and these patients are in their last days of life. The patient's family have to take the prescription, they have to drive around sometimes multiple pharmacies. Now, where I am in East Belfast, that's okay. There are many pharmacies within a stone's throw of where I work. But if you come from where I come from originally, rural areas, people are driving 20 and 30 miles for someone to find stock, and they are wasting, time when they could have been spending that with their loved one. So electronic prescribing would make a major difference in this and many other things.
I'm not sure we heard about I had heard it before, but I'm not sure we've actually heard about the electronic prescribing at any other of the presentations. And I think you're 100% right. It's one of the biggest challenges, because that changes daily as you move through the journey, and that's exactly what happens. So somebody comes in and says, I think that this needs to be increased. They write it up. You have to contact the doctor. The doctor does the prescription. Somebody has to go and lift the prescription. Somebody has to find a chemist to take that prescription. You might be told to come back and lift that later on, and that's grand if you're a family the size of ours. I'm lucky to have all of the support that we had. But if you're on your own, or you're relying on one or two people, if anybody,
what happens when you do that? You could do that and almost miss someone passing, because you're the way things work, and right. it would be devastating. Absolutely. To think about missing precious hours with someone at that time in their life.
Yeah, no, and that has been raised. Yeah. No, thank you, Chair. Thank you, both of you. Thank you.
Yeah.
Yeah, no, thank you, and thank you for everything that you do. I realise how challenging this service is, but how necessary it is. So I do want to say that. When we started this inquiry, it seems now a long time ago, maybe it isn't, but anyway, in my head it is, we were informed by the department, by Mr. Cassidy, that they didn't really know what services were out there in terms of palliative care, and they were going to do a piece of work which would try to bring together all of that knowledge. Has the Royal College been part of that?
No, so we've not been involved in that at all. That's not something that we've been aware of, other than hearing, yourselves talk about this through, various discussions with other people who've given evidence. Yeah, I think it would be.
I'm going to stop you, because this is almost fantastical. In a week that Health has produced some fantastical issues. You are delivering the vast majority of specialist or generalist palliative care to the vast majority of patients, and you haven't been involved in this. That is accurate.
That's right. I mean, we'd happily get involved, and we'd be keen to support any work that was looking at what GPs provide. I mean, essentially, you really just need to count the heads in general practice, because every single GP is involved in this as part of their day-to-day work. But
I think, though, that I mean, I had hoped that this piece of work would produce something along the lines of not just this is a list and a number of all the GPs, and obviously they do palliative care, but this is what they do, this is what they're saying, this is what we could improve, this is what we need to know about coordination with the community and voluntary sector, with the charities, who none of that has happened.
Not to my knowledge, and certainly we've not been approached for any input into that then.
Okay. One of the things that the Minister said, which disturbed me, I think it was an answer to a question from Nuala, was that increasing numbers of cancers are now being detected at A&E. And because they're being detected at A&E, those outcomes are poorer because they may be more advanced. Am I right in saying that?
So I think there's probably a bit of context to that. There will always be cancers which are easy to detect and are detectable at an earlier stage because of the nature of the symptoms. And there are quite a number of cancers, because of the non-specific nature of the symptoms that people present with, they are often later at diagnosis. And we know that whenever you present in a late stage, or you've got sort of advanced disease, often you may present in extremis and you may find yourself in an emergency situation. So we do know that the vast majority of patients who have a cancer diagnosis don't go through an emergency department. They're either going through a GP referral, which might be red flag, or it might be a non-urgent referral, but it's a referral nonetheless. There are a percentage who present to emergency department, and I know some of the figures from the cancer, I think it's the it's a Queen's document that sort of looked at sort of cancer rates of diagnosis. There were about 23% of people presented to an emergency department. I think that's 2018, 2021. But when you look at the trends, that it's slightly reducing over that period of time in terms of the number of patients presenting through an A&E, and more patients are presenting through red flag referrals or non-urgent referrals. But there are a subset of cancers that we're more likely to present late stage, and that would be things like ovarian cancer, like brain, sort of brain tumours, because they often present with things like seizures, which are very, very sort of acute in their presentation. And we also know that there are illnesses like pancreatic cancer or cancer of the bile duct, which again, very, very non-specific symptoms. So it's hard to say, yes, I think you might have cancer and I'm going to refer you. In comparison, if a woman develops a breast lump, it's there, it's very obvious, they'll often see their GP and they'll be seen and sent red flags. So I think we are seeing still quite a number of patients present through an emergency route, but I think we will always see some patients like that because of the nature of how some cancers present. What I think, and where I think we can make inroads in terms of how can we get people diagnosed earlier, because we know again earlier stage cancer diagnosis improves outcomes and survival rates. So access to GP services. So we've talked before at this committee about how we're really worried about the patients out there when they phone time and time again and they're asked by the receptionist, is it urgent? And to them it's a niggling worry that they have, so they can't really say it's urgent, so they don't get seen. And then a week or a month or a couple of months passes before they finally come to us. And those are the people that we're really worried about missing. Those are the people who perhaps are the ones squeezed to the side when we're having to deal with palliative patients and fall foul to our access issues at the moment. And then there's the aspect of screening. So we need to encourage more people to be screened for cancers that, we have a screening programme for. For example, bowel cancer screening, we'd like to see that move from 60 down to 50, where we're actually screening more of our population. And we're encouraging people who ordinarily wouldn't turn up for screening. We need to be able to get out there and reach out to hard to reach groups and say, come for screening, because it can really save your life. Because screening, if we can increase the number of early stage cancers diagnosed through screening programmes, that will have better health outcomes. But in answer to your questions, we will still see people come through emergency departments, but there are lots of things that we could do as a system that would reduce that number, and hopefully that's answered some of what your concerns are.
It's just, I think I was surprised by that number of 23%, and I worry that that's a very traumatic event for people. It's traumatic anyway, but it's a very traumatic event for people in the general sense. I mean, they may well have a very good outcome out of it, but it's just traumatic. So 2 last questions that keep constantly bothering me, and that is, do you find that the vast majority of your patients are able to have that end of life time that they want at home with their family? Is that where it is? And I've recently heard some sort of disturbing stories of patients who have had to be rushed to A&E and have perhaps died with their family not present, or with only part of their family present, and it's been very, very difficult for those patients. Are we still seeing the majority of patients being able to be cared for at home?
Certainly my experience would be that insofar as we possibly can. We try to support people in their homes or in their preferred place of death, because some people will elect and would prefer to die in a hospice setting. But where we can, it's about having those services to provide in the community as in a timely fashion. I think it is important to note that in doing so, particularly where a patient has lots of complex symptoms or you see an acute deterioration that may be something that's reversible, there will be times when there will be conversations about how that's best managed and where that's best managed. And so I think it would be wrong for me to say that patients don't end up in A&E. Should we be striving to make sure that we bring whatever care we can to that patient 100%? Is that about making the services that we have in the community more robust and more able to respond in a timely fashion? Absolutely. Yeah. Because some of that is because that patient has a symptom at that time, and that symptom or the needs of that person cannot be met in a community setting in a timely fashion, and that often triggers the move to an A&E. And we should be able to move from a position where that becomes the default to the default being, well, that community team's already there and they can step in at a moment's notice and they've got the capacity and the ability to deliver that degree of care to that patient at the time.
So really what I'm taking from that is expanding that ability of the community team to respond is important. But I also think that perhaps having the proper protocols in place in A&E and emergency to deal with patients who are specifically in this situation is also important. I'm not sure it is always.
I know that there have been some outreach, palliative care outreach, procedures within EDs, but again, it's piecemeal. It's not across the board. The other thing I would say, just in answer to that, Dan, there'll always be complex symptoms that we just can't manage, and sometimes we have to put our hands up and say, look, while A&E is not an ideal place for anyone in your situation, it is the best place for you because this can't be managed. Social care is a big issue also in this situation. If patients can go, they can go downhill really, really quickly, and sometimes there is a real crisis of social care, and there just isn't the family. There aren't the 10 children there to look after the person, and they sometimes end up in A&E because there are no respite beds. In a nursing home, it may not even be appropriate. There are no hospice beds. So that can sometimes, it can just be a real crisis, and it ends up that A&E is the only place where they can get the care that they need. I think also, as Ursula, as we've talked about advanced care planning and the respect form, we would hope that if this was rolled across the region, that these things would become less, they may happen less and less. It will always happen to a degree, but if we all know what our wishes are, what everyone else's wishes are, hopefully that should happen less.
Thank you very much, and thank you. I think it's important, and perhaps, Chair, we might want to write to the department and ask exactly who is part of this exercise and why such an important element of palliative care hasn't really been included in it.
Fair point. Dr. Mason, Dr. Murtagh, really appreciate you taking your time to come and share that with us. We have learnt new stuff today for our inquiry, so we really appreciate that. Thank you very much.
Thank you for having us.
And apologies again for the shift in time.
Thank you.
Thank you. Okay, members, we're going to item number 7 then, which is SL1, the Human Medicines Amendment related to hub and spoke dispensing. So can I just refer members to papers at tab 7, Clerk Memo 78, SL1 is at page 80, briefing paper page 85. And can I welcome the following officials from the Department of Health: Karen Simpson, Head of Medicines Legislation Unit, and also Chris Garland, who's the Senior Principal Pharmaceutical Officer, so you're very welcome. Just going to hand over to yourself for a brief overview, and then we'll take questions.
Thank you for the opportunity to brief the Health Committee today in relation to proposed legislative amendments to enable all community pharmacies and dispensing doctors the ability to access hub and spoke dispensing should they wish to do so. I would also like to introduce my colleague who accompanies me today, Chris Garland, Senior Principal Pharmaceutical Officer, who can assist with myself with further clarifications members may have to these proposals. Hub and spoke dispensing is a pharmacy model where parts of the dispensing process, like assembling prescriptions, are done in a central hub pharmacy, while patient interactions and final dispensing occur at spoke pharmacies, allowing staff to focus on patient care. Typically, there are many spoke pharmacies to one hub pharmacy. The concept is that the simple routine aspects of assembling prescriptions can take place on a large scale in a hub that usually makes use of automated processes while maintaining the relationship that patients have with their pharmacist based at the spoke pharmacy. Under current legislation, a medicine dispensed in one pharmacy can only be sold or supplied by that pharmacy or another within the same legal identity. The amendments aim to enable the use of hub and spoke arrangements between hub pharmacies and spokes that are either pharmacies owned by different businesses or dispensing doctors, provided medicines are returned to the spoke for final supply. This is made subject to conditions. For example, written arrangements must be in place between the hub and spoke to give a comprehensive statement detailing the responsibilities, and notices about the arrangements must be displayed in order to inform patients. Therefore, these proposals aim to remove the barrier that currently limits hub and spoke models to pharmacies within the same legal identity, and also includes elements to ensure the safe and effective implementation of the policy by putting in place provisions to ensure accountability, governance and transparency for patients. These additional proposals are designed to make sure that patient safety outcomes from the hub and spoke models are equal to current dispensing models. A strategic priority in the Department's Community Pharmacy Strategic Plan 2030 is to maintain and modernise systems for the safe and reliable supply of medicines and professional advice from community pharmacies. Hub and spoke arrangements will not be mandatory. However, enabling all community pharmacies to benefit from hub and spoke arrangements, should they choose to do so, will help community pharmacies to streamline how they manage dispensing workload and release capacity in their teams to undertake more patient-centred services. A UK-wide public consultation on the proposed legislative changes to the Medicines Act 1968 and the Human Medicines Regulations 2012 ran from the 16th of March 2022 to the 8th of June 2022. As detailed in the SL1, the consultation included proposals on two different models of hub and spoke dispensing. Model 1 is where the patient presents a prescription to the spoke. The spoke then sends the relevant information onto the hub so that they can carry out their agreed dispensing actions. The hub then sends these dispensed medicines back to the spoke, which may have further responsibilities to perform, such as providing advice on the medicine to the patient before supplying to the patient. Model 2. The same pathway is followed in that the patient presents a prescription to the spoke, which then sends the relevant information to the hub. The hub then assembles and prepares the medicine before supplying the completed order directly to the patient. Responses to the consultation proposals raised significant concerns to Model 2 and outlined the potential to undermine the relationship between pharmacies and patients, along with risks to sharing accountability for supply of medicines and risks to patient safety. Following further re-engagement with key stakeholders, including the Chief Pharmaceutical Officers in the devolved administrations and community pharmacy representative organisations, the UK Government is proposing to proceed with introducing hub and spoke reform with some amendments to take account of stakeholder views. The revised proposals mean the introduction of Model 1 only at this stage, with the view of introducing Model 2, subject to further public consultation if there is sufficient stakeholder interest once Model 1 has bedded in. The draft Human Medicines Amendments relating to hub and spoke dispensing etc. Regulations 2025, which will amend both the Medicines Act 1968 and Human Medicines Regulations 2012, was laid in Parliament on the 29th of April 2025 under the draft affirmative procedure. The key amendments to note in relation to this SI are only Model 1, patient to spoke, to hub to spoke and back to patient is permitted. The spoke pharmacy must have entered into written arrangements with the hub pharmacy. These must include a comprehensive agreement of the responsibilities each has for the shared dispensing process. The spoke must sell, supply or dispense the medicine to the patient, the hub having assembled or part assembled it under the arrangements. The dispensed medicine must be labelled with the spoke's name and address and the date on which the hub assembled or part assembled the medicine, as well as the usual information required on a dispensing label. The sharing of patient data between the hub and spoke without the explicit consent of a patient is permitted through an information gateway, which includes a requirement for the spoke to display an appropriate notice to patients and staff at the spoke and the hub to maintain the confidentiality of the patient data. Taken together, these arrangements for accountability, governance and transparency of information sharing are key to delivering high standards of patient safety and so are integral to the proposals. The proposals address the concerns raised during the consultation period by ensuring that the spoke pharmacy retains responsibility for the final supply to patients and remains the point of contact for patients' queries about their dispensed medicines. The legislation will not come into force until the 1st of October 2025. This is with a view of providing certainty to the sector and to give time for the Department to consult with community pharmacy representatives on any further requirements, including guidance or any further legislative amendments that may be required to the terms of service and contractual arrangements for community pharmacists as set out in the Pharmaceutical Services Regulations Northern Ireland 1997. With regards to assembly procedures, the HMRs are made under powers contained within the Medicine and Medical Devices Act 2021, and within this Act, the Department of Health in Northern Ireland is named as the appropriate authority in recognition that the regulation of medicines is a devolved matter to Northern Ireland. The proposed SI will be subject to the draft affirmative procedure and will be laid and approved by a resolution of the Northern Ireland Assembly. Therefore, an Assembly debate on this SI will be required. As already mentioned, the SI has been laid in Parliament on the 29th of April, with debate scheduled for the House of Commons on the 2nd of June and the House of Lords on the 17th of June. Following consideration of the SL1 today by the Health Committee on the policy intent of these amendments, if content, the Department will seek to lay the legislation as soon as possible and provisionally schedule the necessary Assembly debate week commencing Monday the 23rd of June 2025 to allow the Committee the opportunity for further consideration of the legislation. Thank you, and happy to take any further questions.
Okay, thank you very much. Danny?
Thank you, Chair. Very interested in this. Thank you very much for the presentation. Just two quick questions. Just want to clarify where the legal and professional responsibility lies in this model. The hub prepares the medications, or part prepares them, and then sends them out to the spoke, which is a community pharmacy who then delivers them to the patients. Yeah. Community pharmacy's name is going to be on it. So how does the community pharmacy know? How can they be sure that the medications that were supposed to be prepared at the hub are indeed the right medications that are in? And I'm thinking a lot of this time it will be blister packs, so it will be likely be a sealed box with some tablets in it that you can kind of see through, but you know, tablets can be any colour, any shape. So where does the legal responsibility lie for being sure that the right medication are in there? Is it with the hub? Is it with the spoke? And how does the community pharmacist know that the right drugs are being given to their patients, who at the end of the day, they are the patients that they're dispensing to? And second question, just with ongoing funding difficulties within the community pharmacy, we've heard that a lot. Has there been an impact assessment undertaken on the hub and spoke models being rolled out in Northern Ireland?
Well, I'll take the second question first, because community pharmacy have asked about an impact assessment, and certainly there was an impact assessment done UK-wide on these, because they are enabling amendments, and there's not a mandatory requirement for pharmacies to undertake to do it. But we are going to work with community pharmacy to consider, you know, our next steps around implementation. Cathy Harrison has already written to Gerard Grainne on the 6th of May just to explain what we're doing with these regulations and to initiate that conversation. So obviously an impact of, we will be considering lots of different things, you know, what we're going to do in the Pharmaceutical Services Regulations, and then what we're going to do in guidance. So, you know, that's probably best how I can explain that one.
No impact assessment has been done?
No impact assessment has been done for Northern Ireland. There's been an impact assessment that will be associated with this SI, and it's published online. Okay.
First question?
In relation to the first question, Danny, both the hub and the spoke will be registered pharmacies in their own right, so both will be subject to the regulatory oversight of the pharmacy regulator, Pharmaceutical Society of Northern Ireland, and the premises standards that apply to registered pharmacy premises will apply equally to both hub and spoke premises. So both pharmacies will be run under the oversight of responsible pharmacists, who will be responsible for the safe and effective running of that pharmacy. So that fits within the existing regulatory framework. The requirement in the regulations is for a written agreement between both the hub and spoke, which then sets out very clearly the relative roles and responsibilities. But I suppose the purpose of the amended proposals is that the responsibility for the final supply of the medicine, the final supply is made by the spoke to the patient, and that's important because it maintains that relationship between the pharmacy and the patient.
Ultimately, they're responsible for the medications that are being delivered to the patient.
They are responsible for making the final supply, but that's not to say that the actions of the hub are not. The hub is still responsible for the actions that they carry out as a registered pharmacy in line with the PSNI's pharmacy premises standards.
It occurs to me then that pharmacists will have to check. They will feel a responsibility to check everything that comes out. Is there 2 checks? Is this a double checking procedure then?
The written arrangements will set out the roles and responsibilities. Now, the legislation isn't prescriptive in that sense. It will be for the hub and spoke pharmacies, and that will again be informed by relevant guidance that is being. We know that the Pharmaceutical Society and the General Pharmaceutical Council in Great Britain are considering what additional guidance is required for pharmacy premises as well, as will indeed the professional bodies as well. So that will be, I suppose, the purpose of the legislation is not to be prescriptive in terms of what those arrangements look like or who's responsible for what. That will be for the hub and spoke to agree.
Agree that among themselves then.
Informed by the relevant professional and regulatory guidance.
Thank you.
Linda?
It's actually just been covered at the same concerns about who, if something goes wrong, somebody gets the wrong medication, whose responsibility is it? So you've answered that, sort of. We don't know because it depends on the on the memorandum of understanding between the hub and the spoke. So,
okay, there's no more questions. So thank you very much. That was very useful. Thank you. So, members, are we content with the merits of the policies and that the department makes a statutory rule? Content?
Yeah.
Okay. Good stuff. Okay, the good news for everybody is that we can move swiftly now to item number 14, which is date, time and place of next meeting. Next committee meeting is on Thursday, 5th of June at 2 p.m. Thank you. Meeting adjourned.